What we'll do, basically, I know the rest of the afternoon's geared towards imaging, so we're going to start out with just kind of introduction to basic radiology. We'll go over some chest, abdomen. We'll get into extremity radiology. And then I'll change slide decks around later in the afternoon, and we'll hit and talk a little bit more about advanced imaging, why you use it, why do you need contrast, things like that. So, but the bulk of this will certainly be geared towards kind of the basic radiology and intro to it with lots and lots of slides. So without further ado, we'll get moving. So I don't have a camera here, so that's me. I had to go in and find a quick picture of myself. This is pre-COVID, so if I could add about 20 pounds to the face, we'd probably be a little more accurate description. I have no financial disclosures, but I'm certainly welcome to be bribed. And objectives, obviously we want to know about what, when, and how to order, understand basic concepts of radiology, how to look at pictures, and most importantly is figure out what the hell is normal versus abnormal. What are you worried about? What are you not worried about? Before you start ordering tests, it's very, very important you get a good history, good physical exam. Once you've done these things, then establish your differential diagnosis. All too many times when I've covered the emergency department and other places, I've had folks say, they come in and they say, oh, my ankle hurts, and you go and examine them. It's really not their ankle, it's their foot. And lo and behold, triage gets an ankle x-ray, which told you nothing. And you then have to order a foot x-ray, which was a more appropriate choice. So, here's the old adage is actually touch the patient, talk to the patient, look at the patient. Once you've established a differential diagnosis, then you can figure out what is the best test to help you figure out what's going on. And that's the key here, is ordering the most appropriate exam to help you rule in or rule out your working diagnosis. This is the only slide on physics, so don't get too excited on me. When x-rays are obtained, it's basically a beam of radiation that passes through the patient, and then there's different degrees of absorption that occur, and that's what helps you kind of differentiate between things that may be normal versus abnormal. The more dense an object, the more absorption that occurs. So in a minute, we're going to see an x-ray with metallic foreign bodies are very, very white, and absence of any kind of absorption is going to be very, very black. And so those are the easy ones. It's all the stuff in the middle that gets to be a little bit more complicated, and that's where we start narrowing things down. Probably the least absorption that occurs is in the air, air or lungs. So if you think about something like a piece of metal in a body, it should be very, very dense or very, very white. Conversely, if we think about somebody with a pneumothorax where it's just air in the pleural space, it'll be very, very black or absence of absorption. So kind of think about those principles when you're looking at an x-ray. All too many times I'll have students look at an x-ray with me and they say, well, that white squiggly line is a fracture. And I hit them with the stupid stick. And I said, no, white squiggly line is dense, not absence of density. If something's broken, there's discongruity, there's absence of density. So it is not a fracture line. So kind of think about those when you're looking at x-ray. So here's a good picture of just a regular patient here. Again, we see this white, dense areas. We see these really kind of lighter white, but not quite as bright as this, which is consistent with organ, in this case, the liver. Obviously, you see some bone. We see some of this cloudy stuff, which is going to be more stool. And then we see this really dark area, which is bowel gas. So, I mean, those are just a couple of varying degrees or shades of gray, as they say. So densities, we talked a little bit about air, very minimal, if any, density. So it's usually pretty black. Fat, a little bit more mild absorption, kind of a lighter gray. And again, this is really going to depend too on what your patient's body habitus is. If you've got a 90-year-old little cacactic little lady, it's going to be a lot different than if you got a 220-pound meathead. So you kind of think about those when you're looking at this. Liquids can vary quite a bit as well, depending on how congealed they are. So those are going to be kind of more of a lighter gray. Obviously, muscle is a little bit more dense, so there's more absorption. And in bone, we hope it's almost white. Obviously, if a patient has osteopenia or osteoporosis, that could certainly change. You know, the idea there is we don't want to be diagnosing osteoporosis off x-ray. If you are, they have a minimum of 30% bone loss, so kind of important. And then foreign bodies, obviously, this is going to vary quite a bit. Easy things like we just saw, coins, metallic objects, pretty easy to find. But when you start getting to weird things like wood or plastic or toothpicks and things like that, it becomes much more complex. So you're not out of the clear because you got an x-ray and you said, oh, it looks okay. Not always. Sometimes foreign bodies, and particularly glass, is another one where unless there's a lot of density to it, you may not see it at all. Terminology, these are some things that your radiologists spit out, and instead of using regular people words, they have radiology language, and these are some of those. So density, how bright or wide is an object? Radiopaque, resistance of passage of x-rays through the beams or through the particular object being x-rayed. Radiolucent, these are your fracture lines. So they'll say there's a radiolucent finding over the distal radius, instead of telling you they have a broken wrist. Lucency, again, these are your fracture lines. Know the difference between AP and PA, and I'll talk about that a little bit later. This is kind of important when you're shooting an x-ray. If you get more, more projection in one particular shot than the other, you may misdiagnose somebody as having cardiomegaly when they really don't. So know which one you're ordering and which one was completed. And obviously lateral is from the side. And obliques are these 45-degree, not quite laterals, and certainly not AP. So if you kind of split the difference between an AP and a lateral, that's the oblique view. And there's a few times where obliques are nice. It's not a mandatory view for a lot of things, but there's a handful of times where it's a little helpful, and we'll certainly talk about those a little later on. So what are some of the key concepts? Make sure it's the right patient. That's kind of important, especially when there's lots of Smiths and Bills and Chris's. Is it a male? Is it a female? What is the date of the film? You folks in the ER and certainly in the ICU like to get about 4 of these damn things a day. So, you know, which film is it that you're looking at? Was this a film pre-op, post-op? Is this the correct film? Is it the correct patient? What's the history of this patient? Do they have body piercings? Did they have a previous surgical intervention that's going to cause them to have abnormal findings on the x-ray? And then when you start doing these, one of the things I always encourage people to do is try to establish a system and do it the same way each time. When you do a ear, nose, and throat exam or abdominal exam, you do it the same way each time so you don't miss things, because it's repetition. And the same thing should be held true with x-ray. The other big thing is, keep in mind, this is a 2-dimensional picture of a 3-dimensional object. In most cases, I don't want to say all, because there's a 1 or 2 exceptions. You want a minimum of 2 views. There again, and I'll talk about, there's 1 or 2 of those exceptions we'll get to in a little bit later. But you always want to look at it, because if you see that little squiggly line, it should be represented on multiple views if it's truly pathological in terms of fracture or obvious abnormality. So when possible, try to get at least 2 pictures to validate and or refute what may or may not be going on. So let's start talking about chest x-ray, and we'll get to some pictures here in a little bit, I promise. Chest film, most common radiological study, ordered daily. What makes it so damn tough is there's a lot of variables. You got blood vessels, air, organ, bone, and they all have different densities. These are what make chest films hard and make it frustrating. And these are why when you take the chest x-ray to 5 different radiologists, you get 6 different opinions. So, you know, the thing that you're looking for is commonality. Do we all agree that this is abnormal or normal? And if it's abnormal, what do we think is abnormal? And then kind of trying to work it up if that correlates with the patient's clinical presentation. Because again, this test is utilized to help you validate or refute. Not, it's, you know, you don't walk into a room, hopefully, after Dr. Chapman's talking and just start shotgunning labs at people and then see what sticks. You examine them, you listen to their history, you ask the appropriate questions, and then you try to formulate a working diagnosis. And you use these tools just like you do your blood test to help validate or refute what you think is going on. Diagrammatic shadows, these are always going to be a little bit higher on the right than the left, as you'll see on some x-rays here shortly. Why? Well, you got this big thing under there called the liver. So think about the anatomy a little bit. Costophrenic angles, these are these imaginary lines which will be very easy to see, and they're important because if they're not nice and sharp on each edge of the thorax, you start thinking about different pathology, including pulmonary effusions and even basilar atelectasis or pneumonias, and sometimes even tumor. Heart shadows, we'll see this diagrammed out. It'll be make much more sense shortly. We should basically have the cardiac silhouette should be about half the distance of the interthoracic cage. And again, I'll show you guys how to measure that. It's stupid simple, and it's kind of a quick dime store way to look and see, hey, does this person really have some CHF, or am I worried about that? So here's a nice picture. Unfortunately, our insurance companies don't let them come like this, right? We don't get this picture diagrammed out beautifully, but I threw this in here because it's a nice one for folks that are just getting started. One of the things I always tell people, you don't have to know everything in here. For example, I don't think everybody can look at a chest film and go, there's the oblique fissure, that thing that Hemmer talked about. No, but I think you should be able to identify some of the major things. Cardiac silhouette, that's huge. We should be able to identify that. The ribs, obviously, very obvious. The clavicle, very obvious. Spinous process, very obvious. The aortic notch as it comes off, very obvious. And then these diaphragmatic, costophrenic angles down in the corners here on the left and the right, very important things. The diaphragm, again, on the right being much higher than it is on the left because of that liver. Identifying that there's things called gastric bubbles, that those aren't super tumors hiding or things like that. So, you know, some of these things are important to at least understand. And granted, each patient's a little different. Their body habitus is different. So it may not always be quite as easy as what we're seeing here. One of the things to know if you got a good film or not is an old article written in Consultant years ago, and it still holds true, is RIPE, R-I-P-E. And RIPE is a nice little acronym that stands for, R is for rotation. Basically, the spinous processes needs to be equal distance from the medial heads of the clavicles, and I'll show you that in English. It'll make a lot more sense. Inspiration is important, that when the patient does it, did they listen to the tech correctly and hold their breath, and making sure that it's an appropriate study. Positioning, you can usually get a pretty good idea if they were upright or lateral decubitus based looking at gas fluid lines, especially in the stomach, because most patients aren't NPO when they come into the hospital or when they're getting their chest x-rays completed. And exposure, this is definitely important, but probably not as big a deal now because of the digital era. Before this, we all had wet films. We used to use the hot lights or spotlights and hold them up and look, and it was a lot tougher. Now with window levels and you can certainly look and adjust that exposure appropriately. So one night, if you're really bored and your Ambien's not working, you can research this on Consultant, and it'll put you to sleep pretty quickly, I promise. So when we look at the chest x-rays, remember I mentioned PA versus AP. And this is, I know it's kind of like, well, duh, this is simple, but there's differences in this. On a PA view, the patient is facing the x-ray cassette, and the x-ray beam is shot from posterior to anterior. This is preferred for optimal chest imaging because the heart and the mediastinum are more anterior, which is going to be closer to the cassette. So you're going to get a true idea of the size of the heart and or if there's any mediastinal thickening or enlargement. However, an AP view where the patient stands with their back to the cassette, this is going to magnify it. Why? Because the x-ray beam hits the anterior part of the chest and the heart is very anterior. It then is magnified from anterior to posterior, and it's going to look larger than it actually is. So if you're really concerned about cardiovascular perspective, a PA view is probably the right way to go. And then when you start thinking about common things that you're looking at, heart size, shape, tracheal deviation, lung symmetry, infiltrates, pulmonary vasculature, what do the CVAs look like? Are there any rib fractures? Are the clavicles okay? Is there any spine fractures? And then obviously lesions and or tube placement. I get called as a spine specialist numerous times for compression fractures off of chest films. So there's a lot of things that you can find off these chests besides just lung and heart, which is the one everybody kind of defaults to and thinks about. Look at less obvious places, things like posterior heart, lung apices. Are there small pneumos? What do the shoulders look like? Is there a dislocated shoulder? You'd be amazed how many times you find things like this. In the Midwest here, one of the things that we see quite frequently, especially with the migrant population coming through, is TB. And for those of you that aren't familiar with that, they will typically have lesions, and they're usually up in the lung apices, so they're pretty easy to miss. A lot of people wonder, well, why the hell do we even get the lateral view? It's worthless. Well, you're looking at a chest x-ray straight on, you see that big heart. Well, what's behind the heart? How do you know what's behind the heart unless you get a lateral view? So a lateral view can help you look posteriorly behind the heart and see what's going on. It can also validate if something's realistic or if it's just a abnormality on the film. And when possible, look at old films. That's always helpful, without question, because especially in these folks that are COPDers, the folks that have a lot of scar tissue and things like that, old films can be really beneficial. When we talk about asthma flares, there's going to be a lot of hyperinflation and flattening of the diaphragm, and I'll show you the differences between that and COPD. COPDers are going to have hyperinflation as well, but they'll have blunting of the costophrenic angles, and they'll have that marked increased AP diameter, kind of that typical barrel chest appearance. So if the fact that they come in paying their copay with the Marlboro miles isn't enough of a signal, these are some of the other things that you may see in folks that are COPD exacerbation versus acute asthma flare exacerbation. Spine sign, kind of a slick little tool, and again, it gives a little credence to the lateral view, and I'll show you guys some examples of this. Basically, as you go from cephalad to caudal, from top to bottom, when you're looking at those vertebral bodies on a lateral view, they should go, if it goes from dark to light, you're thinking about an infiltration. So there shouldn't be a big change there when you go cephalad to caudal, and if there is, you have to really think about there being an infiltrate in that middle to lower lobe, depending on where you see it. Atelectasis, most of you know this, pretty common. Decreased lung volume, very common post-operatively. Really just cough deep, breathe, spirometry, things like that. Pneumothorax, air in the pleural space. These can be traumatic, as most of you know. Obviously, somebody gets pierced in the chest, shot in the chest, bone arrow in the chest. It's kind of a bad day. More typically are spontaneous pneumos. These are seen in young, thin males. Think about these tall, thin basketball players. Most of the time, it's mid to late teens up to very early 20s, and they're spontaneous. And they don't come in with tracheal deviation and saturations in the 80s and all this kind of stuff. These kids come in and they just tell you, I'm having a hard time catching my breath. They don't look sick. They don't act sick. But when you get a chest x-ray, a lot of them will have a spontaneous pneumo. Sometimes they're only 10, 20%, but nonetheless, they still have spontaneous pneumo. So kind of think about that if you're in clinic or in an urgent care and you have one of these kids that fits that demographic, you want to be thinking about that. Granulomas historically are less than a ½ centimeter, and they're very, very dense. You're basically looking down the end of a pipe, down the end of a blood vessel. And so as there's increased atherosclerotic disease, they're become more dense, but granulomas shouldn't change. So if you're looking at something, you go, man, 6 months ago, that thing was a fraction of that size. Now it's a lot bigger. That's a problem. So, don't blow it off as a granuloma. And again, most granulomas no more than about a ½ centimeter. Cardiomegaly, I'll show you guys, as I said a moment ago, how to measure that. It's very, very easy. And then another one, CHF. they talk about these things called curly bee lines, and they're basically horizontal lines found in the periphery of the lungs. And these lines are basically fluid that is captured in the intralobular septae between the lung between the lung upper and lower lobes, between the lobes of the lung. A lot of times these will get mistaken for blood vessels. These things almost always go east-west as opposed to following the typical lung markings. And you should not see any lung markings out in that peripheral quarter of the lung. So if you're seeing that, then you have to ask yourself, well, wait a minute, is this really vessels, or is this CHF? And again, this is another tool to help validate or refute. If you go in there and they got +4 pitting edema, they're short of breath when they lay down and they're better when they're sitting up, and they're wheezing like a freight train, I think it's a pretty safe bet they're CHF. So, kind of think about those things when you're looking at this, as opposed to just counting on the chest film alone by itself. So so in summary, and then we'll get looking at some pictures. Is it the right film? Is the film ripe? Don't forget to look at all the ancillary things, including the bony anatomy, looking at the soft tissue. Here in Missouri, we have lots of folks with extra bone and extra soft tissue. I give a talk sometimes out in the East Coast or West Coast, and they ask me what these folds are in the tissue, and because they don't have as much obesity as we have. So you got to look at that. Is it axillary folds? Is it an abdominal pannus in the way? Know that diaphragm on the right is going to be a little bit higher. Look for nice, sharp costal phrenic angles. And again, the heart size should be about half the distance of the interthoracic cage, which again, I'll show you guys, be easy to understand. Look at the lung side, lung fields. Look at one side, then the other. Are they symmetrical? Look at that trachea. Is it nice and midline? What's the retrocardiac space? And then if you do find something really obvious, stop, take a step back and go, okay, I know that there's A, B, or C, but then go and look for secondary things. Yes, there's a pneumothorax, but is there multiple lung fractures? Yes, there's a little tumor. Is there anything else going on? Try to, again, don't get distracted by it. Really smart radiologist once asked me a question when I was very, very green 20+ years ago, and I wanted to impress him, and he asked me, he said, Chris, you know what the hardest fracture is to find? And I was trying to impress him with some knowledge that I didn't have, and he said the second one. And the whole idea by this is, when you do find something, take a step back regardless, and make sure that that it's truly what you think it is, and is there anything else going on that may be that you're not getting distracted by. So. All right, let's look at a few more things. Unfortunately, your chest x-rays still don't come like this, but you get a little better idea. So when we're looking at this, we see the spinous processes in the middle. We got the clavicles coming in. And when I was talking about that ripe rotation, so here's the spinous process. Here's the medial head of the clavicle. Is this space the same as this space? And if the answer is yes, then that patient's not rotated. They should be in pretty good shape. And then inspiration, we can see the lung or the ribs quite nicely, so there's good inspiration. Positional, we see the gas bubble here, so this is most likely an upright view, and most likely a PA view. And exposure looks pretty decent. It's not whited out or all blacked out, so this is a very appropriate a chest x-ray PA. We can see that aortic knob coming off here. We can see that cardiac silhouette quite nicely. We can see some of the mediastinum here. And then in the corner, we got the costal phrenic angles, obviously the diaphragm that we spoke about, gastric bubble under here. We see a little bit of breast tissue, not to be confused with something else, because again, that overlays, and you don't want to say, well, wait a minute, maybe they got a left lower lobe, hazy, whatever. No, this is just some breast tissue. So again, looking for it from side to side in symmetry. So this kind of gives you a really a dumbed down version of it, but has a lot of the mainstay things that you want to be able to identify and understand if it's normal or abnormal. So here's one. This is what most of us get, is this. There's no drawing on it. So if we're looking at this, we see the bony structures, we see the clavicle, the medial heads of the clavicle are equidistant from the spinous process, aortic knob, cardiac silhouette, costophrenic angles down in each corner. We got the diaphragm a little higher on the right than on the left. And then obviously the ribs, we've got pulmonary vasculature, and trachea is the darker guy. So you see how it's a little lighter down here? And as we follow the trachea up, right here, we can see right where it breaks off into the right main stem bronchus right there. And the trachea being a little bit darker because it's absent. So we see it here, here, here coming down, and about right here is where it's going to split. Again, right main stem and then left. So just some things you want to be able to look at and have a pretty good understanding. And of course, there is a little gas bubble down on this person. Lateral view. So when we're looking at it from the lateral view, obviously chest is here, back is here, cephalad is up here, or head, tail down here. So a couple of things. We've got the heart, so cardiac silhouette, and then we've got the vertebral bodies in the back here. And then we've got the diaphragm. Remember how we had the diaphragm left and right here? So they start up high and then they dive down here, forming that costophrenic angle. So that's the diaphragm. We have the retrocardiac space behind the heart, retrocardiac. And then we've got the retrosternal space up here. So these are areas that you're looking for to make sure there's no gross abnormalities. And then, as I said a moment ago, this is a good place to find vertebral compression fractures, especially in the mid to lower thoracic spine and thoracolumbar junction. Very, very common to see those here. So that gives you a pretty good idea as far as what a lateral chest x-ray should look like. So here's a couple of things. We see some areas that look a little different. The blue arrows symbolizing that abnormality or that difference. But you did a great history and you figured out, this lady had breast implants a few years ago, or many years ago in this case. And so they're just a little calcified. So those are going to look abnormal, but it's not really a pathologic finding. Yes, it's a little abnormal from what we would expect, but certainly nothing that makes us scream and get concerned. If we look at it from the side, you see how there's more increased density up through here. And that's normal, again, because this gal had breast implants. So we don't want to look at that and claim that there's something nefarious taking place when there's really not. So her retrocardiac space looks really good. Dome of the diaphragm looks really good. Vertebral bodies look good. There's a little bit of sclerosis. You know, some people go, is that arthritis? Yeah, welcome to the 30 and over club. It's an early degenerative change. So nothing real exciting there to speak of. The, let's see here. Oop, we don't want that. Let me get rid of that. Sorry, guys. Technology challenged here. Come on. It's not letting me out of that. There we go. Next picture here is, remember I was telling you guys about measuring the cardiac silhouette. And so when we look at this, what you're doing is you're measuring from one side to the other. You don't have to do it by hand. You just want to know, or you don't have to use a stick or measuring stick or anything. You just want to look at that and mark it from one side to the other. Then you can do it left or right. You then take that measure and you lay it right down the spinous process here. And then as long as it stays within the chest cavity, doesn't fall outside the ribs, you can do it left or you can do it to the right. It doesn't make any difference. As long as it stays within that intrathoracic cavity, we do not have cardiomegaly. So if we look at this person and we measure this person from out here to all the way to here, and then we put it midline, that thing's going to fall way out here. So clearly, this is an example of somebody that has obvious cardiomegaly. For those of you who don't look at a lot of x-rays, We have sternal wires here. These little light white things that are going horizontally are sternal wires. And then a lot of these other little things are called vascular clips. So this person's actually had some cardiovascular surgery in the past, and they absolutely have cardiomegaly looking at that. And that's kind of an extreme example, but kind of gives you an idea. So same patient, looking at them from a lateral view, you see those chest wires or sternal wires very nicely. We see all those vascular clips. What about that retrosternal space? Well, there's not a whole hell of a lot there because the heart's so enlarged, it's engulfing a lot of that. And then we also see a little bit of kyphosis here. So a couple of different things that we pick up on this patient. And there's also a little bit of flattening of that diaphragm. Instead of it starting up high and coming down really nice and sharply, it's certainly blunted a little bit, which would make you think that perhaps this person may be a smoker. And so just a couple things to notice on a lateral view. All right, so towards the end of your shift, you're covering the urgent care, and the text says, look, I'm tired, I'm hungry, I want to get out of here. Here's your x-ray. Do you accept this? And the answer is clearly no, you cannot see the whole chest. And she says, okay, fine, here's your other x-ray. Are you still happy? And the answer is clearly no. Garbage in, garbage out. You need to be able to look at the entire chest in one setting to know for sure that everything's copacetic. Just from a standpoint of discussion, if for those of you who are unfamiliar with it, this person has a pacemaker. We see those pacer wires coming down, and I'm sure Miranda could probably tell you more about this than I can. Looks like it goes down into the ventricles. This is probably a ventricular pacer. We see all the sternal wires coming through here, and we also see these little boogers, and these are just skin staples from this person who had a pacemaker placed not too long ago. So those are a couple of the couple things to see on this picture. Another one, which you probably won't care about and are almost no longer in use, are these things. A couple of people used to ask me if those were clips for a gown, and the answer is no. These are what they call anchors for rotator cuff repair, or as patients like to call it, the rotary cup. So this is from an old rotary cup surgery, which they don't even use anymore, those types of metallic anchors. Now most of them are bioabsorbable, and life is good. So just a few things to see on this particular image. This is a lateral view of the same patient. Again, look at the degree of cardiomegaly. We see the pacer wires coming through there. We see the sternal wires, and then we also see quite a bit of degenerative changes within that thoracic spine, loss of disc space. We see a lot of granulomas. These bright little white things are granulomas, not to be mistaken for anything more than that. And obviously, as I said, they're less than ½ centimeter, so we're not too worried about those. All right, so what's the difference when you're looking at these things? How do I know if this guy's got COPD or asthma if he didn't use his Marlboro miles to pay for his visit? And as you look at this, on the picture on the left, this patient has significant AP diameter, barrel chested. Usually it's like a 2-to-1 diameter. So this is very, very widened, which is not normal. Second thing is, look at the diaphragm, how it's pushed down, pushed down. You can see it very well on the AP view as well. That right side is substantially pushed down and probably even a little lower than the left side. And that's clearly abnormal. So we're looking at increased AP diameter, we're looking at flattening of the diaphragm, and there's even, and it's not quite as bad in this patient, but there's even a little bit of blunting of the costophrenic angle on this person. It's not as bad as I've seen in other cases, but it's certainly legitimate. So looking at this patient, again, this patient has pretty flattened diaphragm. Again, look at that right side compared to the contralateral side. Definitely some degree of that flattening. The other thing I talked a little bit about, and this shows it pretty good, we see this pulmonary vasculature coming out, and you kind of see how it kind of comes down at an angle almost. And when we look at CHF cases, that those curly B lines will basically come east to west. They won't follow this normal pattern like this. And then secondly, if you look out in this quarter periphery, out where the cursor's going through, are there any lung markings there? And the answer is no. If we look on the other side, no lung markings. That quarter periphery should be absent of lung marking. And when it is, you're less worried about vascular overload. Here's a lateral picture of that patient. Again, look at that barrel-chested appearance and look at how flat the diaphragm is. So those are a couple of just quick teaching points looking at that particular x-ray. So here's a person I think we could all agree is hyper-aerated. I don't think he had to be in this class or this course to figure that out. A couple of things to really pay attention to that are a little less obvious is look at the diaphragm again, how flattened that thing is. And then I would even argue there's probably some consolidation or maybe even a little infiltrate on that left lower lobe. Clearly hyper-aeration. For those of you that are not familiar with COPD, this is a good, somebody taught me this years ago. I couldn't give credit to it because I don't remember who it was. But COPD is kind of like taking a deep breath, and you guys take a deep breath and hold it. Now hold your breath, you've got a deep breath, hold it. Now without exhaling, take another breath. Well, welcome to COPD, because that's what it is. You got all that air trapping in those alveoli, and you're trying to perfuse more air through it when they're already hyperinflated. So that's kind of a cheap way of scaring your patients with COPD. Another barrel chest. I must have had lots of these on sale, I guess, because this is a really good picture of a barrel chested and a really flat diaphragm. So kind of gives you some ideas there. Again, COPD. So we look at this guy and you say, well, COPD, hold the phone a minute. When you look at the lateral view, is this guy barrel chested? And the answer is no. Is there significant flattening of the diaphragm? Maybe a little, but it's not quite as bad. Look at the costophrenic angles. Are they nice and sharp? And the answer is yes. And then lastly is, what the hell does your patient look like? Is this an 18-year-old kid? The likelihood is he's not a COPDer. If this is a 65-year-old guy who's got leather skin and stained fingers, odds are he's probably COPDer. So look at your patients, listen to your patients. So this is just a good example radiographically of the differences between those two things. All right, so we talked about a thing called a spine sign. Don't look at the left side of the screen, which you're already all doing it, so quit looking at the left side of the screen. Look at the right side of the screen. When we look at this lateral view, you start out kind of light, a little bit white, then it gets a little bit darker. It should stay darker as we go down. However, as we go from light to dark, and then all of a sudden it gets light again, that light area is density. We shouldn't be more dense there. It should be the same color as what we see up here. And so as we go down, we see this increased density. That increased density is the same density that you're now seeing in the very obvious on the right side. So this person has a positive spine sign. I know it's obvious to see on the AP, but I wanted to give you a good obvious example because the lateral view can be helpful sometimes, especially if you're kind of on that page of, is it or isn't it? Well, take a look. What's the lateral look like? Does it give you some help? So this person obviously has a nasty goober there in the right lower lobe, which is easily reflected on the lateral view. So here's another one. This one's a little tougher. So you look at this and a lot of you guys, oh, no kidding, Hemmer. Well, guess what? It gets a little bit harder when you don't have big blue arrows pointing towards the abnormality. So if we're looking at that picture, compare it to the contralateral side and you'll see if we look over here, we have nice normal pulmonary markings. That's what we should see. And then we've got this big increase in density. We see all this consolidation right through here and all the way up to here. So there's definitely a goober, for lack of better words, in this zip code. So something's going on there. Doesn't tell you exactly what it is. It just tells you that it needs more attention. And when we look at it on the lateral view, first of all, cardiac silhouette's a little hard to see, but I would say it's probably right in this zip code here. So if that's the cardiac silhouette, What's this big thing? Retrocardiac. What's this big thing? Retrocardiac. So again, here's a good example of where the lateral could kind of say, oh, wait a minute, something's not right here. Even though it wasn't as obvious here, when you go to the lateral, you should be stopping yourself and go, oh, wait a minute, that retrocardiac space is pretty crummy. Something is going on there. And this person clearly had a pretty significant right mid to lower lobe infiltrate. I think everybody could look at that and figure it out. These are the easy ones. It's the ones prior to that that are a little bit tougher. Here's one, right upper lobe. The other thing, if you look at this picture, I think everybody would agree there's a pretty good pneumonia here, but there's also some, probably a little bit of a pleural effusion down here. If you look at the contralateral side, nice and sharp costophrenic angle, and we go over here, and clearly it's not as sharp. There's quite a bit of blunting there. This one shows bilateral parenchymal infiltrates, basically double lobe pneumonia. So just more of the same, just you're seeing it on both sides. Here's an example of a patient that has one of those curly B lines. And when we're looking at this, first of all, a couple things. Number one, it's not the greatest x-ray in the world. Part of it's probably body habitus. They kind of got this chin on chest deformity, which makes me wonder if they don't have a lot of kyphosis. We see the lines from the sternotomy. So this person's probably got a pretty ugly ticker. We see all this changes out in the mediastinum out here, and then the heart silhouette way the heck out here. So I think it's pretty safe to say this person's going to have some CHF. Further complicated is we see this vascular marking going east to west as opposed to the pulmonary markings kind of going down and away. So when we're looking at this, we see this kind of east to west business. That is indicative of that intralobular septae or fluid in the intralobular septae consistent with increased pulmonary fluid or certainly CHF. Do you have to have that to make a diagnosis? Of course not. It's just a little more x-ray help if you needed it. And then here's your lateral view. Obviously, the cardiac space is just packed because this person has significant CHF and certainly significant cardiomegaly. Here's another couple examples from one of the textbooks that show those curly A and curly B. My understanding of curly A's is just the different lobe, the upper lobe versus the middle lower lobe. But nonetheless, you're looking for those dense lines, and they're almost always going kind of east-west as opposed to following the normal pulmonary vasculature. But again, it's just an X-ray finding. So here's a patient, big pleural effusion. When you see something like this, the question at hand is what's causing this? Lots of different things can cause pleural effusions. Obviously, tumors are one that everybody gets worried about, and certainly reasonably so. Newly diagnosed rheumatoid arthritis can cause pulmonary effusions. So this is a problem. This guy's or this gal, this person bought themselves an admission and certainly a CT to figure out what the heck's going on in there. But clearly this is a bad thing. But you're going to expect something ugly because you've already examined them, you've listened to their lungs, you've percussed them, all these things that you learned a million years ago. These things are important to use in concert with the radiographic findings. And then the lateral view of that same patient, you can see how it's almost worthless because there's just so much fluid in there. That's just, you really just don't see much good anatomy at this point. So, you're kind of got a problem. This is a CT of that same patient. When we look at this, is called a coronal cut, where we're looking straight at the patient and slicing them from belly to back. You can see this, all the black is the lung, and you got the vascular, pulmonary vasculature, the white guys. You see this nice costophrenic angle. You got the dome of the diaphragm here. And then you get over here and you see this solid density. Now, this is not a solid mass. It's more likely a pleural effusion. And the reason for that is it's got this meniscus line. If you remember meniscus back in chemistry, if you took a test tube and had fluid in it and looked at it from the side, you kind of have this meniscus. It's a little higher on the edges and then it has this little bevel or dimple, and then a little higher on the other edge. So they call that a meniscus, and it's also why meniscus in the knee looks like it does. That's why they named it that way. So this is again a pulmonary effusion, certainly on that left side. This one I threw in because I thought it was interesting. You know, we'd all look at that, and the first thing we would all jump on is CHF. And but I challenge you guys, take a step back and say, okay, we know this heart is huge. We can see that. They got massive cardiomegaly. However, if you look at the pulmonary vasculature, if we're looking at the pulmonary vasculature out here, does that pulmonary vasculature extend out to that quarter periphery? And the answer is no. Do we see any big curly B lines? And the answer is no. So there's no pulmonary congestion. So if this is CHF, why is there no pulmonary congestion? Well, the reason is it's not CHF, it's a pericardial effusion. So if this person comes in and they're in trouble and you see this chest x-ray and you start throwing Lasix at them, you didn't help them, right? So this person's got a bad problem, but it's not a volume overload problem. It's a problem that they got too much, they got fluid around the pericardial or in the pericardial sac, causing decreased perfusion. So I threw this in just to kind of throw it out there to keep folks from assuming things, because that's a bad thing to do in our world. Here's another patient. If you didn't do a good history and you didn't realize they had a portacath, you might not think about lung cancer. And you look at this x-ray and you go, holy crow, man, how the hell do you see lung cancer here? Well, you're looking at it on the AP view, you know, this person definitely has some breast tissue, which overlays a little bit. But then when you look at it, you start seeing this much more dense area here, which is irregular. Well, if that didn't sell you enough, you got the lateral because you listened to this course and now you're smarter. And as we look at the lateral, and it goes from light to darker to what is this big thing? Because that's not the diaphragm. Diaphragm's down here, heart's up here. What the heck is this thing that my cursor's all over? So you would have got the lateral view and look at it and go, holy cow, something nasty's going on here. So again, another example of where the lateral can kind of save your hiney if you can get it, it's worth doing it. Here's an interesting case. This was a patient I took care of. They went to the ER, got the obligatory EKG because they didn't feel good, had a little bit of cough, smoked a pack a day, didn't feel great. White count was about 12, 13,000. Gave them some, I forget whatever the bug juice of the day was, sent the guy home, told him get a chest x-ray in a couple of weeks and you'll be fine, life is good. So the guy shows up to my office about 3 or 4 months later, and 3 or 4 months later with back pain. And so I'm like, holy cow, this guy, you know, he's only 50 years old. He's got this destructive lesion. What the heck is it? And so we started talking. I was like, you know, have you been sick? Have you this? Have you that? And he said, well, yeah, I had pneumonia a few months ago. So I got a chest x-ray in my office just for giggles. Probably the only time I've ever done that in 20 years. And what was diagnosed as pneumonia here, and reasonably so, is clearly not pneumonia, as I give you guys seizures because I can't use a computer. Clearly is not pneumonia here. So there's a good reason why you get follow-up chest x-rays post-treatment. Again, typically around 4 weeks is the appropriate time frame to make sure that there's document resolution. Had this guy gotten a chest x-ray, it would have shown that this lesion was persistent, and it may have helped some, but it certainly wouldn't have led to much different. He clearly now has metastatic disease and did not do well. So here's another example of a tumor mass. You can see it's very consolidated. Sometimes it's hard to say, well, is that a tumor or is that just an infiltrate? At the end of the day, I think it all depends on how your patient is presenting. If they're having night sweats, fever, chills, weight loss, cough, hemoptysis, I'm a whole lot more concerned about a tumor than I am a patient who's, you know, 25, 30 and doesn't feel good and their lungs sound like crap and they got a little fever. Well, then treat the patient, you know, but again, make sure you get that follow-up chest x-ray and make sure that you document resolution. There's a picture of a hilar mass. pretty straightforward. This one's probably not something you're going to see very often, but I threw it in here because it was interesting. This patient had a total left-sided pneumonectomy secondary to cancer, but you would know that because you did a great history, and when you examined the patient with his shirt off appropriately, you saw the big shark bite incision on his left thoracic cage consistent with thoracotomy. So when you listen to his lungs and you didn't hear any lung sounds, then you get a chest x-ray, and of course it validates your findings. Now, with this alone, if you got a lateral x-ray, is it going to be very helpful? Because Hemmer said you had to get 2 x-rays. So you got a lateral, and it's very unhelpful for obvious reasons. You're looking through that big scar ball. So this is a case where it really wasn't a whole lot of help, but it at least gives you an idea what's going on the residual lung that's still there. Here's a patient, I wanted to show you guys, had some rib fractures, status post-motor vehicle accident, left lateral rib pain, and the big blue arrow demonstrates multiple fractures. He did not have a flail chest. He only had 2 or 3 fractures, so not a definitive flail chest, but certainly has good reason for pain. When, a lot of times patients they'll have a trauma, they'll have pain with inspiration, they'll have pain with palpation. It's worth getting a chest x-ray, one, to look for the chest, look for the fractured ribs, and it's also beneficial to make sure they don't have a lung down or anything obvious. So, but that's just for your own edification. We're seeing. Have I seen patients that their films look pretty normal, but I thought they had a rib fracture? The answer is yes. A lot of times I tell the patient, I'm not going to do anything different other than, hey, if they're just bruised or contused, they're going to get better in a week, 10 days. If they're fractured, it's going to probably take you a good month and a half. So avoid contact sports, activities, things like that, where they could fall or injure it. So just a couple things to see from a chest perspective. This is a patient with pulmonary fibrosis. Thought it was kind of interesting because you can see all that fibrotic tissue. You see what appears to be a fusion on the right lower corner here. We don't see that nice normal costophrenic angle like we see on this guy. And the lateral view, again, you see all this fibrosis within the lung tissue. Really makes it hard to see anything because it's superimposed on normal tissue. And this is what a CAT looks like on a guy like this. Obviously on the asymptomatic side, we see this nice normal pulmonary vasculature and nice pulmonary markings. On the bad side, we see all of this fibrosis, and then there's actually a small pulmonary effusion down in here, and that's what we were seeing on the AP view, or PA view, excuse me, where there was blunting of that diaphragm, or blunting of the costophrenic angle. So basically, that's kind of what you're seeing in that regard. And this is an AP view, same thing. You see all this pulmonary fibrosis going on in here, and then we see this consolidation. Again, that's just a pulmonary fluid from the fibrosis. Atelectasis. You basically you get a little bit of consolidation in the base of the lungs. Again, not real impressive. Very common finding post-op. Typical turn cough, deep breathe, spirometry. In some more severe cases, percussion. Consider MDIs. I don't know that I've ever seen anybody need a bronchoscopy because of it, but I'm sure if they were unable to get up and move around, if they were paralyzed, if they had something more ominous taking place, that may be a reasonable approach. But for most folks, they're able to take care of this by just getting their butt out of bed and get them moving. So here's a gal who presented to the ER with back pain. So of course she got the obligatory EKG, and of course she got her chest x-ray. And on the chest x-ray, she's actually, lungs were fine, heart was fine, but she has a compression fracture down at T12. So here's an example of the chest film diagnosing a compression fracture in the thoracolumbar junction, no less, but still a compression fracture. So, when we think about these chest films, we've looked at all kinds of different pulmonary pathologies. We've looked at various cardiovascular pathologies. Now we're looking at bony pathology. When we look at this person gets a chest x-ray, and what I want you to see on here, the dark, the block arrows, we see this real bright or white, this real dense area, and then we kind of see this little dome over it. And you see how this is straight across. The only thing that's going to do that is fluid. So that's called an air fluid line. So this patient has a huge hiatal hernia. So if we're looking at this, and then we look at them on the lateral view, we can really see this as we pointed out now. We see this air fluid line. This is all air because it's dark, it's dense, so there's lack of consolidation. Second concern is, here's the heart. This is retrocardiac. There's not supposed to be anything here. So looking at that, you know, hey, there's something screwy here. And then we go back and look at it on the contralateral side, on the AP view again, and we see this nice outline of the bowel. So basically now we're diagnosing a GI problem with your chest x-ray. So again, got to be able to think broad spectrum here. And again, so now we're looking at a patient came in acute short of breath. If we look at the picture on the lungs on the side here, we don't see, we do see nice pulmonary vasculature. That looks normal. If we look over here, do you see any pulmonary vascular markings at all? The answer is no. What's left of the lung is right here, that's outlined. So that lung is been compressed from out here all the way into this, and this is a huge pneumothorax. So when you come in, you put a chest tube in here and you let all that air out, this will then re-expand up and out. So this person has a massive, actually it's a tension pneumothorax because it's so huge. And we actually can see the trachea lateral to the right as well. So there's a good example of a tension pneumothorax. And in case you didn't have enough pneumothorax, we gave a guy one on the other side. So here is the lung. Here is all air. You don't see any markings at all because there's nothing here. There's nothing but air in here. So when a person gets a chest tube here, decompresses the intrathoracic cage, then this lung will then re-expand out. Life is good, as opposed to all the pulmonary vasculature markings that you see on the left side. This is an unusual one, but I threw it in there just to see it. This patient actually has a pneumopericardium, pneumomediastinum, and a lot of this was found because he had free air under the clavicles or above the clavicles, the typical Rice Krispies. So for those of you who have never seen free air or felt free air, you only need to do it once. It's basically like Rice Krispies under the skin. When you see that or feel that, it's a bad day. Something horrible is going on. And you actually look at the picture and you can see the heart, and then you see a little space between it and the white arrows. The white arrows are pointing to the pericardium. So there's a pneumopericardium, there's a pneumomediastinum, it's a little harder to see, and then a lot of air under the apices, or above the apices. That's diagrammed out there. So, you know, the big take home here is if you find free air on palpation, it's a bad day. And they're not always going to come in severely dyspneic and tell you, hey, I got a pneumopericardium or free air. They're just going to tell you they don't feel good or they're having a hard time breathing. So again, here's a good example of touching the patient, examine the patient completely, not just trusting the tests. All right, so we're going to keep moving on. We're going to get to abdomen now. So with abdomen, obviously has lots of different names. KUB, flat plate, primarily looking at lung bases, gas patterns, soft tissues. These can be helpful according to the literature for bowel perforation, ruptured ectopic, ileus ovarian cyst, AAA, ischemic bowel obstruction, or foreign body, to which I say probably about one or two of these is reasonable in the real world. If you're worried about ectopics, you're not going to do a flat plate. Ileus, very reasonable. Ovarian cyst, waste of money. AAA, waste of money. Ischemic bowel, waste of money. Bowel obstruction, maybe. Foreign body, maybe. So, I mean, I think you got to really kind of decide what's your level of concern before you start doing this. If you think somebody's got something bad, order the appropriate test. An ectopic pregnancy is better worked up by ultrasound, not a flat plate. AAA, if you're worried about it leaking especially, is better worked up by CT. Bowel obstruction, contrasted CT. So we want to look at organ shape, size, calcification, all of this good stuff. Looking for asymmetric psoas margins, which I'll tell you as a guy who's done spine for 20 some years, I've never seen that. They talk about it pathologically 25% of the time. So I'm 0 for 25 because I've yet to see asymmetric psoas margins. You can also see skeletal structures, SI joints, thoracolumbar vertebral bodies. Organ size, again, very hard to diagnose on plain x-rays unless it's significantly extreme. I think it's helpful to look at bowel gas pattern. You're always going to have some bowel or some stool and gas and things in the stomach and in the colon, because again, most people don't walk around in an NPO status. When you think about bowel, and we'll see the difference between SBO and ileosis here in a minute, most of the bowel is found in this very good description of the left, mid, lower, central abdomen. So basically all over. But when you're looking at small bowel have these very small lines called, these very small mucosal lines, and they almost look like stacks of coins. Like in the old days, we used to roll coins, and if you looked at it from the side, that's kind of what they look like. So here's what a small bowel obstruction would look like. If we're looking at it, there's these small stacks, one on top of another, and that's very consistent with a small bowel obstruction. And we'll see the difference between that and an ileus here momentarily. In the cecum, typically the colon itself will have more of a bubbly appearance from the mixture of stool and gas. Colonic air has been described as a clover leaf shape because of these short haustras or longitudinal bands. And then obviously think about where the colon is. You've got the ascending colon, then you got the transverse colon coming across, splenic flexure, and then descending colon to the sigmoid and out into the rectal vault. So thinking anatomically where those areas are, and then the small bowel is kind of stuffed in between there, if you will. So when we're looking at it, this is a classic example of a large bowel. These little guys are called these haustras, these very short bands, but they're spaced wide apart. Unlike the small intestine, where they're very tall and skinny and stacked one on top of another, in the colon, they're very short and they're widened. So those are some big differences when you're looking at it. What are some red flags when we're talking about the abdomen? Free air under the diaphragm, huge red flag. Any kind of free air on supine film is a problem. The third one I think is nonsense. If you're seeing that, then you've kind of missed the bus in my world. And then the last one is really important. I stress this especially to new grads and students, is in the presence of acute problems, pain that's been going on for 24 to 48 hours, severe pain, fever, elevated labs, or a strong clinical suspicion, CT is the way to go. We've all had those patients have been in your office 5 times in the last 4 days for the same belly pain, and they've already been scanned once. The likelihood is you don't need to scan them again. You got to think about radiation exposure. On the flip side of the coin, if you got somebody who, hey, they got a little rebounding, they got a little guarding, they got a little tenderness, then you have to think about that. Is that really what's going on? I will tell you myself, and I know other people on this call have sent people to the OR for an appendectomy who did not have severe pain, did not have a fever, and had a white count of 10, 10.5, and may or may not have a very mild left-sided shift from Dr. Shanna's talk. So, again, it's clinical suspicion. So that's huge, not the person who's in there every other day because their dilaudid level is low and they need to get something done.
when you're looking at this, this is just some of the basic anatomy. Cholecystectomy clip. We know this is a Missouri patient for two reasons. Number one is their gallbladder's out, and that's kind of prerequisite to live here. You got to have your gallbladder yanked. And the second is they got a fat fold. I just don't see these in other places. So we see, in this case, we can see a little bit of the liver. We certainly see some bile gas pattern. I don't think you can buy that this is an inferior pull of the kidney. I think that's kind of phooey. And we certainly can see the SI joints. So there's a lot of things that you can see here, both skeletally speaking, as well as soft tissue structures. So here's one that's not diagrammed out. We see a normal bile gas pattern. When we're looking at this, these are just normal bile and stool. That's a normal thing to see because, again, people don't walk around NPO. For those of you that aren't familiar with these kind of films, this is not a fracture. This is a younger patient who is not skeletally mature yet. So they have growth plates, and that's a normal finding. And this is a male patient, as evidenced by his stuff. And then again, here we got the same kind of picture of that. And again, we see this stool and colonic gas kind of mixed together there, coming into the transverse colon and working its way down towards the descending colon. This is a picture of a patient, 21-year-old lady who was celebrating her first job as a teacher. She was playing a game called Quarters, and she thought she might have swallowed the quarter. She called her doc the next morning. He said, rush to the emergency room. She comes to the emergency room, no pain, no bleeding, no nothing. Looks at me with these white, big, starry eyes and says, what are we gonna do? And I looked at her, was serious, and I said, I think we're gonna see if you can make change. And we left it at that. So, you know, is this an emergency? Of course not. She has no shortness of breath. She has no bowel symptoms. At most, you can tell them, look, dig through your crap and see if you find your quarter later. If you want to be a little more dignified, you can get an x-ray in a couple of days. Now, this is a little different than a kid swallowing something that's of concern. With kids, and I'm not a pediatric person, so if you guys are out there, correct me if I'm wrong, but in pediatrics, you typically want to include all the way up to the chin, make sure there's nothing stuck up by the carina. This certainly is different if this person had swallowed magnets or things that may perforate the colon, sharp pins or pointed objects. That's a whole different story. But on things that are nice, round, and non-caustic, typically you can let it run its course and life is good. So looking at this picture, we see these haustras. These are short haustras and they're wide apart. They're not stacked on top of one another. So if we look at this picture, I would hope most of us would be able to look at it and go, okay, this person's got a huge ileus, and that's exactly what it is. This is all large intestine, markedly enlarged because of ileus. The small bowel is not involved per se, and this person does not have a SBO. This person has a huge ileus, certainly decreased narcotics, ambulation, maybe some stimulant, whether it be suppository, things like that would be very reasonable. Some people had mentioned, hey, throw an NG tube down this guy. And my question to you guys is, if you do that, is that going to decompress the intestine? Because you're putting a nasogastric tube in, meaning that it's going to float around in the stomach. Is this problem in the stomach? And the answer is no. This patient has a problem in their colon, not their stomach. So throwing an NG tube down does nothing to make this better. So just something to think about when somebody comes in, they got an ileus and somebody wants to drop an NG tube. Unless they're puking their brains up or they've got a lot of air and fluid in the stomach, you're probably not going to gain much and you're not going to make them real happy. So just something to think about. All right, looking at this one. If we look at these haustras, they're very skinny, they're tall, and they're stacked up one on top of the other. So hopefully by now you guys will look at this and go, clearly this is an SBO, and you would be correct. This person has a small bowel obstruction, not an ileus. So those are some of the big ones between SBO and ileus from a GI perspective. Now, you look at this one, you say, well, wait a minute, that looks just like ball gas in the stomach. And you would be right, except the stomach's not on the right side. So looking at this, this person has free air under the diaphragm, and free air under the diaphragm equals surgery. So if the person had surgery recently, such as a lap chole or a GYN procedure or a urological procedure, you need to be calling that person and tell them they have a problem. If maybe they have diverticulitis and they had a diverticulum that ruptured, then the general surgeon's got a problem. At the end of the day, somebody other than you or I have a problem here, and it's a surgical problem. So free air under the diaphragm equals surgical consult. That's an easy way to put it. You can also use these things to look at foreign bodies. Again, I don't do much GYN at all. I shouldn't say much, I don't do any. But last time I looked, those things that you stick up there, those IUDs, they don't look like that. So probably a good way to look at that and say, hey, wait a minute, this is a problem, this is migrated, and obviously would need to be addressed. These are some pictures of things we see out in St. Charles quite a bit here in Missouri. The urologists go out onto the aqueducts and they pour calcium oxalate into the water to create kidney stones so that they can pay for their kids' college. And when we come in with the kidney stones, they put these fun little stents up into the ureters, which they lyingly tell you won't hurt to take out. Don't ever let them take one out while you're awake. Insist to go to the OR because they hurt like a son of a gun. This is a picture of a stone. This is a cute little 7mm stone. This is the axial cut of the stone, so these things are no fun. There's actually a little bit of perinephric stranding on this CT scan. So this guy actually had a pretty good sized stone impaling the ureter. That happened to be mine about 3 years ago. So I speak from experience, they're no fun. And this is not my picture. This came from Derek Leffert, Home Collection. No, I'm just kidding. It's not Derek's. All right, so moving on. We're going to go to skeletal radiology because I want to make sure we have plenty of time. And again, if you guys have questions, I'm trying to watch that chat box or just bleep in and interrupt me. This is a small enough group. So are you guys doing okay thus far? Not going too fast, too slow? Somebody said great, great. Okay, thumbs up. There's a middle finger. I can't see who that is, but no, I'm just kidding. All right, so moving on. Skeletal and hands. Again, what you want to do is good clinical exam. Is this the 80-year-old who's been crocheting and now their hands hurt? Is this a guy who works on the assembly line and has some carpal tunnel? Is this the 18-year-old hothead who punched the wall because his girlfriend doesn't love him anymore? Obviously, 3 different scenarios, 3 different diagnoses. So you want to look for some symmetry of the carpal rows. We're going to talk a little bit about scaphoid tenderness because that's a big one that you don't want to miss. You know, typically if folks have tenderness or what we call the anatomic snuff box, you want to have a concern for a scaphoid fracture, which could lead to what we call avascular necrosis. When in doubt, splint it up. Nobody is going to be upset because you put them in a splint. If they got pain, swelling, trauma, and you put them in a splint and then the x-ray comes back final read as negative, nobody's going to be upset with you. However, you missed the tiniest insignificant little chip and you're going to hear about it till the end of the day. So, you know, a lot of times, again, immobilization, ice, elevate, compression, some of the basics, and even if that means using a boot or an OCL splint or, you know, something like that, very, very reasonable. When we look at this, I'm not going to go through all the diagrams, but they're here for your own edification. However, when we talk about anatomic snuff box tenderness, obviously we got the thumb as it comes down here, and where the hand and the wrist meet, this area forms what they call the anatomic snuff box. And if we were in live, I would show you, just walk around and pick point on everybody. However, this area is consistent with where the scaphoid is, this guy, or the navicular, whichever you want to call it. So if you're palpating that area and a patient has a lot of tenderness, that should be concerning, and you can see it on this side as well. Well, why is that? This particular bone is very unique in that it has one directional blood supply. And so if a waist fracture occurs, if there's a fracture across the scaphoid, one side gets blood, the other side doesn't, and you can end up with what they call A, meaning with, well, excuse me, A, without vascular blood, necrosis, death. Without blood equals death, and that means that the other half of that bone dies. And so it's kind of a big deal, and it's treated more aggressively many times than just a splint or a cast. A lot of times you'll shoot a screw through there to pull those two bones together to ensure that they heal appropriately. So it's a big deal. If you have risk or concern of scaphoid fracture, I would recommend putting them in a thumb spike, a splint, ice, elevate pain control, and a referral sooner than later. Doesn't have to be at 2 in the morning, but that's not something to wait a month or two or even 2 weeks kind of thing. One of the most common degenerative pathologies in the hand is CMC arthritis, carpal metacarpal arthritis. And when we look at it at the hand x-rays, a couple of normal things. These little round bones are called accessory ossicles. Those are not chip fractures, so they're very normal. We find those in the thumb. We also find them in the toes. Another place, as I said a moment ago, that CMC joint, very common area to find osteoarthritis. Now, on that view, it's not real impressive. However, if we go to this view and we look at that and you think about it like a saddle joint, if you look at this picture, the left hand, we can see how that saddle joint is wore down and it's actually subluxing. So it's probably about 1/4 to 1/3 of the way subluxed from where it should be. And that can cause a lot of pain. And this is just typical wear and tear overuse type scenario. This is the kind of thing we see because obviously we're not simians. We use thumbs, we oppose, and obviously that can lead to premature arthritis. Remember what I said before, one view, no view kind of thing. If we look at the x-ray on the top, not too many people would be real excited by that x-ray. However, if you get the x-ray below it, now you get your second view, all of a sudden everybody gets a little bit more impressed. So this is a good example of what we call a PIP dislocation or proximal interpharyngeal joint. And this is very easy to take care of with just a little distal traction, and this will reduce nicely and it's pretty easy to do. But again, the point being is that you want to look at more than one x-ray because sometimes you get duped. Again, if we looked at just this, it'd be a pretty hard sell to say anything real obvious is going on, but clearly I think all of us would agree that this guy is pretty abnormal. So here's a picture of that scaphoid I was talking about a few minutes ago, our navicular view, and the arrows are demonstrating a fracture, a midline fracture of the scaphoid. And here's a good example of what it looks like when it's not treated appropriately. And now you got a big problem because now you got a big hunk of dead bone, and it doesn't matter how long you put them in a cast, that joint is going to be trashed. So now this person's going to need a significant operation, and they're going to probably always have some degree of morbidity with it. And you know, this is just a bad problem that should be avoided by identifying the pathology early on. Here's a couple more pictures of scaphoid fractures. If you guys notice that picture on the right, that looks like the person's fingers are pointing the opposite way. That's called ulnar deviation. So if you're looking at your hand and you ulnar deviate, you bring it towards the pinky finger, that's how that x-ray is taken. And they call that a scaphoid view. There's an ulnar deviation and then there's a radial deviation. So you can do it both ways. And then you would certainly get your AP lateral and oblique views on top of that. So if you have a patient that has scaphoid tenderness or navicular tenderness and you're worried about it, just when you order your x-rays, put on there scaphoid pain or obtain scaphoid views or 3-view wrist series with scaphoid views, and any of the radiology techs will know what that means. So because that's a very common thing to order, and sometimes it can help identify, especially if it's not real easy to see. Sometimes that ulnar and radial deviation views can give you a little bit better help as to whether or not you truly have a scaphoid fracture or not. So x-rays can be helpful. Obviously, this is finger versus saw. Saw wins. Do you need an x-ray to tell you that the guy's got a jacked up finger? No, of course not. But why is this important? Because if you're going to call plastics to help you out, you can say, look, I've got an open distal phalanx fracture and there's no interarticular involvement, meaning that the joint looks okay, but it's an open fracture here. This can be taken care of in the ER with just a digital block. You digital block this, clean up any of this soft tissue, rongeur down some of that dead bone, and put it and basically close it. If there's a joint involved, the risk of infection skyrockets. So if you're getting this patient, you definitely want to make sure they're up to date on their tetanus, make sure their antibiotics are appropriate, and certainly doing a digital block will give you adequate pain control without giving you a ton of side effects. So that's really the biggest important thing here when you're getting the x-ray of this, is to identify whether or not there's joint involvement. Here's a good old-fashioned picture of osteoarthritis. If we look at these pictures, we got an AP and an oblique here on the left and a lateral on the right. We see these big old spurs coming off. Those are called Burchard's nodes, and then we also have Herberdine's nodes, which are the ones that you see on the PIP joints. Now, interesting thing I want to make sure I drive home. When we look at these joints, you say, well, yeah, they're arthritic. We get it. And we see that. We see the big spurs here. However, look at the PIP joints. Strike that. MCP joints. When you're looking at the MCP joints, do you see much arthritis? And the answer is no, you don't. So here's the take home. Osteoarthritis, run-of-the-mill osteoarthritis, is going to affect the DIPs primarily, occasionally PIP, and rarely, if ever, MCPs. Okay? Now, the difference is rheumatoid arthritis almost always affects the MCPs significantly and rarely the DIPs. Can you have both? And the answer is yes. My point to this is lots and lots and lots of patients that you guys will see and I've seen will say, oh, I got rheumatoid. And you say, well, are you on methotrexate? What do you take? And they look at you inquisitively because they have no idea what you're talking about. They're using the wrong word. They think the word arthritis means arthritis, so rheumatoid is an arthritis, so clearly I have rheumatoid. No, they don't. They got osteoarthritis. So you got to be careful about that. So one of the easy ways to do it is just remember, rheumatoid arthritis, MCPs, osteoarthritis, DIPs. And can you have a combination of both? The answer is absolutely. So here's a good example of an oblique and an AP. We see those DIPs are really trashed. We see some in the PIPs, but those MCPs are really pretty pristine. So just kind of drives it home. And they also have really crummy CMC joints down in the thumb, which we would expect, again, because they have significant degree of osteoarthritis as it is. All right, so now we got our hothead, the 18-year-old kid at the high school. Girlfriend breaks up with him. Boy punches locker. If we look at these MCPs, we see nice MCP, and then we don't see an MCP very well at all. This is what the mechanism is. Here's the blue guy. It represents the wall or the locker, hothead punching it, and the metacarpal neck is displaced, and that's kind of what we see on the clinical exam. Radiographically, this is what we would see, this disruption of the metacarpal neck, and very, very common. This is what a lot of you guys will hear is like boxer fracture. If you want to use that word, great. Just make sure you're using it appropriately. This is truly a boxer's fracture. Here's another example of a boxer fracture. Again, this is right at the metacarpal neck, and so that's a pretty typical thing to see, nothing too exciting. Here's another one, just a lot of angulation. Sometimes we'll actually try to reduce these, put them in a short arm cast. Sometimes there's some other types of splints that can be utilized. Certainly no emergency, but maybe put them in an ulnar gutter if you got to buy them a little time in an OCL, and then send them off to your friendly neighborhood hand or orthopedic person. This is a fracture of the base of the fifth metacarpal. This is not a boxer fracture. Boxer fracture occurs at the distal end. This is at the proximal end. So a little bit different things. So you just don't want to mix up the nomenclature. If you're not sure, just call it what it is. Hey, they've got a fracture of the distal metacarpal neck, or they have a fracture of the base of the fifth metacarpal, or an impacted fracture of the base of the fifth metacarpal. That's just as good. Nobody's going to be upset that you didn't use the fancy orthopedic word to describe it. So just describe what you see. And if you're really not sure, of course, here's the disclaimer: stick with your hospital's policy, but it's kind of nice to be able to take an x-ray, de-identified, of course, and shoot it over. You know, years ago, we didn't have all that cool technology. Now you can take a quick picture and shoot it over on your iPhone or whatever, and be able to get some help, or at least some direction. Here's a good example of a proximal fifth oblique fracture, the fifth digit. So this is the phalanx, this is the metacarpal. So make sure you know the difference. And then we see this oblique fracture, which is easily reproduced on multiple views. And this is a very easy thing to take care of. Put them in a luma splint, finger splint. You want to always splint them in natural position. Natural position is not stuck straight out. Natural position is usually about 20 degrees, 30 degrees of flexion, and then buddy tape, Illuma splint, ice, elevate, activity modification, anti-inflammatory, whatever you need, whatever you choose to use for pain. So again, remember we said one view, no view. Nothing real exciting, maybe a little chip if we really wanted to get technical on that distal phalanx. However, now you get the next view, lateral view, and you see there's absolutely a little something there. So this is called a tuft, T-U-F-T, tuft fracture. Very common injury. This is the typical thing you see when the guy's working on the deck or the gal's working on the deck and they hit their finger instead of the nail. This is what they get. So pretty easy to identify. Big thing is, you know, treating it if it's open, if it's bleeding, you have to technically treat it as an open fracture and counsel them regarding the possibility of infection. Although these are very low likelihood of infection, you have to at least broach that topic. Certainly tetanus shot, splinting. They have these little caps like fingers, protectors that are aluminum that you can slide over the end to keep them from bumping it. If they have a big subungual hematoma, you can certainly drain that. Some studies argue if it's more than about 25 to 30%, you ought to consider draining the subungual hematoma if it's acute. Obviously, if it's chronic, don't waste your time. Again, one view, no view. Oh, there we go. So I think everybody's a little more impressed with the second one. With this guy, pretty easy to take care of. Of course, you have to numb it up. You'd have to reduce the fracture, remove the nail, fix the nail bed, put the nail back on. Very timely, but not hard to do. But if you got a waiting room full of people, it's no fun. If you got an hour to kill and there's not a lot going on, it's a pretty easy thing to take care of. Post-reduction, they look great. It wants to go back to where it belongs. Here's some examples of typical degenerative crud. You know, these are always tough because they send the old lady in that's 90 years old, non-communicative, and oh, her wrist hurts. Well, I'm not sure how you know that, but okay. And so you're looking at it, you know, is there point tenderness? Is there ecchymosis? You know, on a case like this, if the patient had pain, I'd probably put them in a splint and forget about it, because who knows? I mean, it's just a mess inside there, and you're certainly not going to operate on something like that. So typically, when in doubt, splint them up. But this is classic degenerative stuff. So if there's an acute injury, you can put them in a splint, ice, elevate, treat it like a fracture. If it's, oh no, this has been hurting like this for 10 years, there's no big change, there's no point tenderness, certainly treat it as an arthritic process. Maybe a topical agent may be beneficial if they're advanced age and they have kidney problems. And of course, all you cardiology people put everybody on blood thinners, so it makes the orthopedic jobs harder. So maybe get by with just a little topical agent, some topical diclofenac, or even a Laderm patch or something along those lines. It's an interesting x-ray. I wanted to show you guys that this patient actually has more calcium and crud in their pipes, their radial and ulnar arteries, than they actually do. The patient has significant osteopenia. You see all that, just really, bone is really crummy. So this person obviously high risk for fracture and MI, because they got horrible pipes and they got horrible bones. So just a couple things that you can see on x-ray besides fractures. Oops. This is a picture of a patient, fell, outstretched hand, had some wrist pain, point tender, but the x-ray wasn't very impressive. So you got your AP, you got a weak oblique here. It's not the greatest oblique. And then we got actually a second oblique and then the lateral. And when you start looking at him, you start seeing that dark line in there. And that dark line is actually a fracture line. So this patient actually does have a distal radius fracture. And so this is actually pretty easy to treat. Put them in a splint. They'll eventually get a short arm cast, but no significant angulation, which makes everybody's day easier. You want to check neurovascular function. Certainly make sure that they have good pulses and that sensation is intact. Ice, elevate, sling, try to keep it above the heart, kind of the basics there. This patient also has a distal radius fracture, although this one's slightly impacted, really no significant angulation. So you could say, hey, they got a slightly impacted distal radius fracture with no significant dorsal or volar angulation. Again, very easy to treat. Put them into a splint if you're in a clinic or in the ER urgent care, and then turf them on, and they'll eventually get a short arm cast. So moving on to elbows. Elbows a little tougher, a little more concerning at times, especially in younger population. Typically, you want to get 2 to 3 views. Number 3 is probably the clinical pearl here, looking for a thing called a Sale sign. And a Sale sign is also called an elevated fat pad sign. These can be both anterior as well as posterior. When a Sale sign is observed, you have to treat it as though it's fractured and consider it fractured until proven otherwise. A lot of times folks will sustain radial head fractures, and they'll also have a Sale sign on the x-ray. Radial head fractures are pretty easy to identify even without an x-ray, just clinically. Radial head fractures will typically occur from fall, outstretched hand backwards. So if the patient is, for example, roller skating and their skates fly up, they throw their arm out behind them to catch themselves and they load it. That's a typical injury for a radial head fracture. Radial head fractures will present very classically. They'll have their arm flexed at 90 degrees and their palm will be to their belly, and they won't want to move it. And so you say, okay, well, let me see you turn your palm up. And they actually keep their palm on their belly and they almost bow at the waist. And it's like, well, that's great, but now let me see you turn your palm up. And they don't want to do it because that's turning that radial head. It's moving that radial head, which is fractured, and it's not fun. They also don't like to extend their elbow because it hurts. So typically these patients will not want to demonstrate extension. They will not want to demonstrate supination because they have significant pain with those activities. So when you see those things, you better be thinking about a radial head fracture. And then of course, when you see that, don't assume it's the only injury. Check their wrist, check their shoulder, check their clavicle, make sure that nothing's hiding. Again, don't want to miss that second fracture. Here's some examples of what it looks like on the AP and lateral view diagrammed out. Again, the picture on the right is a kid elbow because we see the growth plates are still there, but the anatomy is still pretty much the same. These are 2 examples of those fat pad signs that I talked about. The anterior fat pad sign, obviously here in the front, and then the posterior fat pad sign here. As I said a moment ago, you do not have to have both. If you got one or the other, it's a fracture until proven otherwise. In kids, and again, I'm not a kid provider, but in kids, if they have a positive fat pad sign and the x-ray looks okay, you still treat it as though it's broken because some kids will have what they call a supracondylar fracture, and that's a fracture that occurs above the condyles, up in the supracondylar region, and that can actually lead to growth discrepancy in the distal humerus. So you don't want to miss that kind of stuff. So when in doubt, splint it up and punt it to the appropriate place. If it's a young kid, PD ortho, if you've got that, is the way to go. If you don't have it, then routine orthopedics is certainly reasonable. But again, splint it up and treat it. When you see these fat pad signs, you need to be thinking fracture. Here's an example of the patient that I just showed you a minute ago with the fat pad sign. This person actually has a radial head fracture, minimal displacement, so this one will do okay. The problem with a lot of these is that they really have a lot of decreased supination and loss of extension because it hurts so much, they don't want to do it. It's okay to do general range of motion, but we don't want to load those people. We don't want them pushing up like on a desk or pushing up out of a chair, because it can displace those fracture fragments. If there's significant displacement already, then a lot of times operative management should be considered. But on a routine non-displaced or minimally displaced distal radial head fracture, typically early mobilization with therapy, but cautioning them that there's certainly risk of decreased extension and decreased supination just by the nature of the incident and anatomic findings. This is just a spur that we see inserting where the triceps inserts. This is not a fracture. Patient had a little chronic elbow pain. Get an x-ray, you're like, man, you got a big spur, some calcification, maybe an insertion of the triceps tendon. But otherwise certainly not a fracture. So again, do they have point tenderness? Do they have mechanism of trauma? Using your clinical exam and history to support radiographic findings. And this is an AP view, same thing, nothing very exciting. It's a dislocated elbow. These are pretty tough, especially in kids or adults, doesn't really matter. Before trying to reduce these, you better make sure you have some backup, because if you do reduce it and the ulnar nerve gets entrapped, then you go to the OR right away to get that released. I have not ever had an elbow that I have done. I will tell you, this is not a nursemaid's elbow. That's subluxation of the radial head, which is much simpler thing to take care of and is done a lot of times on accident. Patient, you just supinate and pronate them, hyperpronate them, and they reduce right away. This is truly an elbow dislocation. The humerus is dislocated from the radius and ulna. So that's a much different deal than a nursemaid's elbow or a subluxation of the radial head. This is what it looks like post-reduction, so it goes back quite nicely. And if the nerve is entrapped, they're going to know it right away, because they're going to have significant ulnar radiculopathy, sometimes even some weakness, and it hurts like hell. So it's not going to take long, and they're going to be very specific, that pain down into the 4th and 5th digits. This is a typical thing we see in the spring. Kids out riding bikes get ejected over the front, throw their hands out. This, if you're looking at this and you're describing it, very simply, it's a both bone forearm fracture with dorsal angulation, and it's a distal both bone forearm fracture. So when you're talking to somebody, if you don't have the opportunity to send them a picture, think about, you got distal, middle, and then proximal. And so that's how you're going to describe it. Both bones are fractured, and then there's some dorsal angulation. So pain control, check neurovascular status. These will do actually very well. A lot of times, the younger the kid is, the more that bone will remodel, meaning that even if it's got a little bend or a little crook in it, it'll actually grow out. If you have the same fracture in a skeletally mature patient, it'll stay that way unless it's straightened out. A lot of times we'll want to give that a little help, try to straighten it out a little bit, and then put them in a long arm cast so that they keep it from moving. Same kind of deal, except now we got a both bone forearm fracture with significant angulation, and this is going to be more of an operative problem than the last one we looked at, but nonetheless, again, it's a lot nicer now. You can just take a picture and send it over, but that's kind of the descriptors that you would utilize. Treatment still the same: pain control, neurovascular status, splint, ice, and refer. So let's move on. Skeletal shoulder. Again, with shoulder, a lot of this is, how much, where do they hurt? Is it anterior? Is it posterior? Is it lateral? Not everything's the rotary cup, as a lot of patients like to call it. There's a lot of different pathology that affects the shoulder. From a bony perspective, obviously, you can have trauma, certainly have chronic degenerative changes. When we talk about dislocations, over 95% of dislocations will be anterior. Sometimes you get a little glenoid chip fracture from a dislocation, so you need to look for that. Even if you do find the dislocation, you want to make sure that there's not a chip off that glenoid, and if there is, that's fine, just document it. Looking for AC joint symmetry, make sure there's not a acromioclavicular disruption, and there's a lot of different grades of those depending on if that AC ligament is just sprained versus a full thickness tear. Looking for clavicular fractures. Almost all clavicle fractures are going to be mid-shaft. If you're finding clavicle fractures that are closer to the midline, a midline clavicle fracture, you have to think about a higher velocity of trauma. Same thing with scapular body fractures, and same thing with high cervical ribs, like ribs 1 and 2. When you're finding these kind of things that are broken, that usually correlates with a high level of energy or high level trauma, significant ejection off motorcycle versus tree, things like that. So yeah, it's a little outside the scope of primary care, but again, you see some of the things. If you're seeing that, hey, I need to be thinking there's probably more here going on than just a skeletal injury. This is diagrammed out for your edification. You got the distal clavicle, AC joint is this guy, and again, that acromioclavicular ligament is what goes across here. So when people separate their shoulder, that's what gets injured, and that allows it to ride up. Glenohumerus, the glenoid, that glenoid chip comes from off here. Certainly coracoid, easy to see. Greater tuberosity is where the rotator cuff comes in and inserts. Rotator cuff comes across underneath the acromion and inserts into that greater tuberosity. So that's kind of a common thing to see. And just, again, just kind of the basic anatomy, just so you know what we're talking about, and when you're looking at the x-rays, what you're looking for, and have a little better idea what may or may not be the pathology. When we talk about shoulders, just like any other joint, you can certainly have arthritis. As we're looking at this, there's significant glenohumeral arthritis, and we see a big spur coming off here. So just like hips and knees, we can have arthritis in the shoulder joint. Now, this is a little different. This patient actually presented with decreased range of motion of their shoulder. They denied any recent trauma and got an x-ray. And if you look at it, there's really something missing here. You see the proximal humerus here, or you see the humerus, proximal humerus, but we don't see the ball at all. And this patient actually, what we believe happened, had a fracture at one time. And what ended up happening is she probably sustained an injury at one time, broke the proximal humerus, never had it fixed, and ended up with avascular necrosis, and the head just died. So this is a very complicated problem, because now she's got this stem and basically a pseudo joint, false joint, but it's all connected with soft tissue. So, you know, it's like, well, do you do a shoulder replacement? What do you do with this patient? It's kind of a hard call, but nonetheless, this is a typical ambulatory patient. So you see weird stuff like that every now and again. This is a good example of a shoulder dislocation. Typically when we're looking at this, we see the clavicle, we see the acromion, and then there's a complete disruption of that acromioclavicular ligament, which allows this guy to ride up. You'll definitely see a deformity on the skin. The question then is, hey, is this fractured, or is it a AC disruption or separation? And that's where the x-ray comes into play. Obviously, this is a picture of an AC disruption or AC separation, acromioclavicular separation. So that's what it would look like. In cases that are not as severe, sometimes this thing could just ride just a few millimeters up, and they can have a lot of pain over it. So maybe they've got like a grade 1 AC separation, or even a grade 2. I mean, there's some things like that that can be described. So when you see those kind of things, you know, they can certainly be there without having this full thickness separation. So basically, you still treat it the same way. Here's an example of a dislocated shoulder on the left, an anterior dislocation, and this is the picture of the reduction on the contralateral side. One reason we know that is the ball is up where the socket belongs, that we see here. Second reason is I gave her sedation and I had her on a monitor when we did it. And those are actually pretty easy to do. You just got to have adequate sedation, and otherwise they're not real hard to accomplish. This is an unfortunate injury. This is a patient who has a proximal humerus fracture. And you look at it, I always describe these kind of like an ice cream cone. You've got the scoop is knocked off the cone. And the problem is the x-ray really doesn't do it justice. This particular patient had a CT scan, And when you look at the CT, I think you better understand the severity of this injury. Here's the proximal humerus, and then we got the humeral head, which is knocked off by about 50%. And then there's substantial comminution within that component. So this is a pretty significant injury. You know, years ago, before the day of shoulder replacements, a lot of times you just put these people in a sling and a swath and just our shoulder immobilizer and left them alone. Depending on how active that person is, you may or may not want to refer them on for more therapy in terms of possible shoulder replacement. If this is an 80, 90-year-old person who's not very active and not very functioning, you know, a shoulder immobilizer is more than adequate. If this is a 60-year-old person who, you know, is pretty active, they may very well go on to get a shoulder replacement. So really it depends on each person, but nonetheless, kind of a catastrophic problem for that particular patient. This is interesting, and it's a really crappy x-ray, and I apologize for that. This person actually was ejected off a motorcycle and clinically doing reasonably well, except their shoulder blade hurt, and they actually had a shoulder blade fracture. So they have a pretty good sized fracture of the border of the scapula. Really not much to do for this other than pain control, put them in a sling and limited activities. Nonetheless, it still hurts like hell. I thought it was an interesting x-ray, so I threw it in there. These are just examples of mid-shaft scapular, mid-shaft clavicle fractures, as we've been discussing. And they look pretty nasty. Typically, these you can treat with either a shoulder, a sling or a figure of 8. Either of those are very appropriate. A little pain control, activity modification, and those patients will typically do very well without any significant difficulties. Here's one that's more of a green stick, for lack of better words. And then we see kind of an incomplete fracture here on a kid. Treat them the exact same way, except the kids will be bouncing around in a couple of days, whereas us 18 and over crowd, we're going to be milking this for a couple of weeks, if not a few months. So moving south, let's go to the pelvis and the hips. When we're looking at the pelvis, this is one case where one view is very reasonable. I had mentioned before, one view, no view. AP pelvis, that's one of the exceptions. So one view pelvis is very reasonable. Look for widening of the symphysis pubis. You're looking for to help delineate whether there's unstable fracture. I tell folks all the time, people can walk in on hip fractures. I'm not telling you they're tight or they're not skipping rope, but there are people that will walk in and will definitively have an insufficiency fracture or an incomplete fracture of their hip. Most fractures in the hip occur at the femoral neck. Be cognizant of this as patients will typically present. They won't come in and tell you, oh, my hip hurts. They'll tell you my butt hurts, my groin hurts, or my thigh hurts, and in some cases, even my knee hurts. So when you hear those kind of things, you really have to evaluate whether or not it's a hip fracture versus a groin versus a knee problem, and that's where physical exam comes into play. When you're looking at patients that you have a high index of suspicion, people who cannot bear weight, you have to be worried about insufficiency fractures. Looking at something called Shenton's line, which I'll show you guys here in a little bit. The other thing is patients can also present very similarly and have what they call a pubic rami fracture. And a pubic rami fracture is okay to bear weight on, and these are typically a little more common. You'll see those in younger patients as well as older patients, but the complaints will be very similar: groin pain, anterior thigh pain. The difference is when you range of motion the hip, in a person with a pubic rami fracture, they tolerate it. In a patient with a hip fracture, they clearly don't tolerate it. And you know, not every patient with a hip fracture has the shortened internal rotated extremity like everybody describes. So kind of the thought here. So when we look at the diagrammed out view, we see the SI joints, we can see the acetabular femoral components, and then you've got the greater and lesser symphysis pubis, and usually when these guys break, these pubic rami, they usually break in two places. Think about it like a lifesaver. Lifesaver, you can't really break it in one spot. So if it's a ring, which this is a pubic ring, usually if it's broken on the superior, it's going to be broken inferior. Those are okay to ambulate on. But when the femoral neck is broken, that's a whole different story. Those are the ones that absolutely require operative management and are not able to be ambulated. I mentioned Shenton's line. Shenton's
Did anybody else lose audio? I can't hear you right now.
I can't hear him either.
Yeah, I can't hear anything.
Maybe we should send a note.
I sent him a message in the chat box.
Oh, okay.
Can you hear me now? Oops. Hello?
Yeah, I can hear you now.
You okay now? Can you hear me
We
okay?
can hear you now. You're good. You're
Okay.
good.
Okay, good. Thank you. All right, sorry. I don't know what happened. I don't know. Anyway, sorry about the technical glitch. So I'll start off with the hip again. So when we're looking at the AP pelvis, this is looking at it straight on. Obviously, this person has significant osteoarthritis on the right hip. If we look at the left hip, we see a pretty good acetabular femoral component, and that's what we want to see. If we look at that Shenton's line on the good side, starting on this inferior troch, and we come up and around, it's really pretty smooth. That's what it should look like. If we go to the contralateral side and we do the same thing, we see there's clearly it rides high here. So again, it doesn't mean it's broken. It just suggests that there may be some abnormalities there. So this person clearly has end-stage osteoarthritis of the hip, and this person needs a total hip or live with it, one or the other. Let's see here. So this lateral view or outlet view of the same thing. Again, if we look at this, we see all these cystic changes in the hip. We see a lot of spurring coming off that acetabulum. This person has a lousy hip, and they will certainly present with growing pain, thigh pain, and sometimes even knee pain. Here's an example of a pubic rami fracture. This one is easy to see on the inferior pubic rami. And this is actually a younger patient. This was a patient of mine who was sliding into a base, second base, who was safe, by the way. And she got her leg twisted up, and she actually busted her inferior pubic rami. Hurts like heck, but a wheeled walker, a little pain control, and she was good in a couple of weeks, and within 6 weeks she was back playing again. So they typically heal up pretty nicely, but very different than a hip fracture. This is a pubic rami fracture treated much differently. Picture on the left, before we jump to the blue arrow, let's go to the other side. If we look at Shenton's line, again, we draw that up. It's really a nice concentric soft half circle. If we do that on the contralateral side, we see there's clearly abnormalities. And this patient has a femoral neck fracture. Unfortunately, it's displaced enough that it needs what they call a bipolar prosthesis. So this fracture gets this solution, and that incision extends from here all the way down. So it's a big open surgery. And so you can see how that could really increase mortality in the older population. You know, you take a patient who's 80 or 90 years old and something like that happens, well, that's kind of a big deal. You know, I mean, that's a lot of surgery, and it's a lot of blood loss and mortality and morbidity that goes along with that. Here's another example of a femoral neck fracture. If you follow it up, you see this, basically it's impacted here. So there's no question that there's a fracture of the femoral line. Somebody asked me, go back and talk about Shenton's line. All right, let me back up for a minute. Shenton's line is this imaginary line that goes from the inferior pubic rami, and it comes up and around. And we should see that nice soft arc all the way up. And again, Shenton's line can be affected by arthritis, and it can be affected by fracture. It can be affected by positioning. It's not an absolute. It's just another tool. So, you know, if we go and we look at Shenton's line here, we see this looks really pretty smooth, not too shabby. But if we do it on the side that has end-stage arthritis, clearly a big, big difference. Or if we go to this, you won't see it on there, you only see it on the AP view. So if we go to this AP view, here's Shenton's line. Looks really good. Even though she has a pubic rami fracture, Shenton's line still is perfectly intact on both sides. And on this particular patient with a fracture, on the non-fracture side, Shenton's line looks great. On the fractured side, clearly it's off. So hopefully that makes a little bit more sense. And I'm sorry, that's probably where I broke off on the audio. Here's another fracture, the inferior pubic rami, or excuse me, there's another fracture of the femoral neck, impacted femoral neck fracture. Unfortunately, just like fingers and toes and other things and shoulders, you can dislocate. When you have a prosthesis dislocated, it's a very hard reduction. So most of these go to the operating room. Although some guys will say, oh, try to put it back in. I can tell you it's almost impossible without knocking them out with conscious sedation or even full sedation, because it's just so hard to get that thing to reduce. But nonetheless, those can dislocate just like real parts, fake parts can dislocate as well. This is an interesting case. So it was actually a patient, one of my colleagues, who was walking around, living in a relatively rural area, complained of a lot of hip and leg pain, was sent to physical therapy. I guess nobody examined her. Continued to have pain, was eventually sent to orthopedics. And if we look at the left side, we see this nice ball and socket where it's supposed to be. Everything's pretty normal. But if we look at the right side, look at the ball, which is about 50% gone, and look how it's riding up and basically eroding into the acetabulum. And actually, there's probably a little bit of a stress fracture going on at the acetabulum here as well. So this patient had this problem forever, and she actually was walking on this and getting around. She just kept talking about how her hip hurt and therapy wasn't helping. Can't imagine why. So nonetheless, you know, you can find some of these quirky things. Again, you just want to examine the patient, and certainly getting a plain radiograph is not a bad thing. We talk about knees. Again, is it traumatic? Is it chronic? One of the big knee fractures that we see is a thing called a tibial plateau fracture. These are typically fall on a flexed knee. They're usually very swollen, and the pain is way out of characteristic for what you see. So if you got a patient who's just really hurting, you have to think about that. That doesn't mean that they have it. It's just one of those things that it's one of those where, hey man, this person really hurts a lot more than I would expect. Is that a possibility? I've only had a handful of these in 20 years, but they do happen, so just kind of be aware of them. More times than not, we see the chronic knee pain, obvious osteoarthritis, patellofemoral syndrome, chondromalacia. These are all more common things to hear and see when you talk about knee problems, especially in younger folks. Here's a diagram of them for you. If you need to review that, you certainly can have that. A little more remediation. This is a lateral view of it. If we look at it again, we got the femur here, we have the patella, and then we've got the tibia, and we see the fibula back behind it. We see a little bit of arthritis on the superior pole of the patella. The AP view historically is going to be the real helpful picture. When you look at that, one of the things you want to make sure you have your folks do when you order a knee x-ray is get a weight-bearing AP view. That's the picture on the left. Weight-bearing AP view. Why? Because most x-ray techs, when they get an x-ray of the knee, they hop them up on the table. How many of your patients go around life levitating, not loading their knee when they get an x-ray? So I've seen patients who have been told, oh, you have mild arthritis, you have no arthritis. And then you get a weight-bearing AP view and all of a sudden they have significant to end-stage osteoarthritis. So that's something to think about, is make sure you get a weight-bearing AP view. The picture on the right is called a sunrise view. And as we look at that, we're looking at the femur. Here we got the femoral condyles here and here, and then you got the patella. So you're shooting down the knee. You should see this symmetric spacing on each side. So this person, even though they're younger, has significant maltracking of the patella, or they have some patellofemoral syndrome, pain going up and down steps. A lot of times a tracker brace or a knee immobilizer can help, or knee brace can help that. Certainly physical therapy with vastus medialis oblongus x-rays, VMO exercises. So, it's a couple different reasons for knee pain looking at these two different, starkly different x-rays. This is that picture of the tibial plateau fracture that I was talking about. If you look at it on the lateral side, and for those of you that aren't real sure what I'm talking about, the lateral side is always the side where the fibula is. So if you're not sure, hey, is it lateral, is it medial, it's not marked, look for the fibula. If you know where the fibula is, you know what's lateral. So, but if we look at that lateral side, it's depressed when we compare it to the contralateral side, and we see that on more than one view. So this is a patient who actually had a tibial plateau fracture, specifically a lateral tibial plateau fracture. And we actually got a CT of this because the question in the head was, well, if there's no displacement and you put them in a knee immobilizer, non-weight bearing, they could probably do well and manage them conservatively. However, if there's significant displacement, then they really require operative management. Otherwise, they're going to end up with a horrible joint, osteoarthritic joint. So this person actually did very well. There was minimal to no displacement. So they were placed in a knee immobilizer, non-weight bearing status, and they actually did reasonably well. Patella fracture, actual fracture of the knee. Obviously, this is kind of a significant problem. They're going to have a lot of pain, swelling. This requires operative management. If you think about what attaches, you got the superior pole and then the inferior pole, and those big tendons that connect those two guys. So if this is disrupted, you have to have that put back together. Otherwise, that's not going to do well. So you can also get proximal fibular fractures, and this actually occurred. This is one that I missed. Here's my dirty laundry. This kid came in, had a significant lateral malleolus fracture, a lot of pain in the ankle, rolled it, and had a high torque injury. And I took care of his ankle. Life was good. And he kept complaining of knee pain, and got the x-ray a little later and realized, oh, stupid stick. I missed something here. It doesn't change his outlook, but I should have recognized it. Again, the second fracture. And I will preface that with, that was a long time ago. But nonetheless, if you're unsure and you're palpating that lateral part of the knee and the person has pain, just get a knee x-ray. You don't have to get a tib fib, but a knee x-ray will tell you that because it's right next to the joint. And especially if you have a substantial torquing mechanism where planted the foot, torqued, had a substantial injury to the lateral malleolus or medial malleolus, it's well worth taking a look up at the proximal fibula. Again, if you squeeze it and they don't have any pain, it's not broken. Think about it. If it's broken and you squeeze on it, it's going to hurt. So you just want to check that proximal fibula when you're checking folks with ankle injuries. So moving south or distally, foot and ankle, obviously very common stuff. Where are they tender? I talked about that earlier. Do they have, is it really the foot? Is it the ankle? Is it the toes? Where is it that they hurt at? Looking at the ankle mortise, looking for ligamentous injury, and I'll show you guys differences on those films. When in doubt, if you think you got a calcaneus injury, go get a calcaneal x-ray, and I'll show you the difference between those. And there are specific views you can get. Even if, again, if it's negative, if they've got significant soft tissue swelling over the lateral malleolus and it looks like a fracture, smells like a fracture, but the x-ray just doesn't show it, it's still a pretty significant soft tissue injury. Nobody's going to fault you for putting that person into a splint, non-weight bearing, ice, elevate, typical conservative modalities. So it's very reasonable to do, even in the absence of an obvious osseous injury. So when we look at the x-rays, a couple of views here. The AP view is pretty straightforward. This is an oblique view, and these obliques are kind of helpful in the foot and ankle because it opens up those metatarsal rays. So if you look here, it's pretty hard to see the base of those metatarsals, but when you get the oblique, you can see those metatarsal rays all the way down, and it opens up quite nicely to make sure there's not a fracture in those metatarsal, the proximal aspects of those metatarsals. So that's one area where the obliques can be very, very helpful. This is diagrammed out. Obviously, you've got the medial malleolus, lateral malleolus, and then you've got the talar joint here and the calcaneus. Again, this is not a calcaneal view, but you do see a calcaneus there. And there's a different view that I'll show you guys if you're really worried about a calcaneal view. Calcaneus injuries typically will occur if somebody jumps out of a tree, like falls out of a tree stand, or they jump out of a second story to first story type landing. Those types of injuries are very common. The other thing to be cognizant of is if the patient does have a calcaneus injury, then you have to be concerned about lumbar spine or thoracolumbar spine injury. So think about that energy transference, you know, because calcaneus injuries hurt so badly that a lot of times they're not even thinking about their back or other places, and they're certainly non-ambulatory. That's really a significant injury if they break that calcaneus. Difference between AP and mortise. AP view is straight on at 90, but a mortise view is rotated a little bit or angled a little bit so that it opens up the joint space. And so when you're looking at the joint space, we should have equidistance between the medial, lateral, and then tibia and talar joint. So it should be pretty much that congruent joint space all the way through. If it's not, then the question is, okay, what's going on there? Is there a ligamentous injury? For instance, is there a deltoid injury off of the medial malleolus, or is there a lateral malleolus fracture, or even a soft tissue injury off the lateral malleolus? More times than not, if there's mortise disruption, it's going to be off of this deltoid side because of the off of the medial malleolus because of a disruption of the deltoid ligament. When you examine those patients will have substantial tenderness when you're palpating that area. So if that's the case, then obviously you need to immobilize them, and sometimes even in the absence of fracture, they'll require operative management. That doesn't mean emergently, but certainly immobilizing them, keeping them non-weight bearing. Just like we saw arthritis and all these other joints, these patients has arthritis as well. Significant arthritis in the tibio-talar joint. A lot of times these will go on to get fused. In some cases they do ankle replacements, but that's kind of a very specific niche. Here's a good example of a patient, and these are not mismarked. This patient actually presented with bilateral calcaneal fractures. This is the right, obviously the left. And if you look at that, you see some of these lucencies, and those lucencies are actually fractures. When the calcaneus breaks, it's not like a twig where it just breaks in two. It more or less shatters. And if we look at this next view, This is the true calcaneal view that I was talking about. This is one of those two patients, or one of that patient's, his left foot. If you look at that, you can really get an idea of how substantial that injury is. That fracture extends all over the place. So this is really a bad, bad thing. And think about, you know, especially bilateral fractures. How does this guy ambulate? Now all of a sudden they're going to get pressure sores and DVT risk, PE risk. I mean, this is really a big deal for a guy that just broke his foot bone. You know, this is a big deal. So again, on these patients, always make sure you check that thoracolumbar junction to make sure that there's not an occult fracture because of the way that these injuries occur and the degree of energy it takes for these injuries to happen. That's certainly something you got to be very concerned about. More commonly are base of the fifth metatarsal fractures, also called Jones fractures. These are very common. Typical mechanism is I was walking down the driveway and I rolled my ankle. It has nothing to do with their ankle, but they actually fractured the base of the fifth metatarsal. Easy to see, easy to find, easy to take care of. Usually put them in a boot. As long as there's no significant disruption or space, those typically will heal without incident. They're a little bit easier to see on an oblique view. As you can see, once you start opening those metatarsal rays up with angulating the foot, you can identify the fracture much, much simpler. Here's another picture of a base of the fifth metatarsal fracture. Again, these people will have pain over the foot, but the mechanism is, hey, I rolled my ankle and this is what happened. Another thing to note is we see these sesamoid bones in the great toe, just like we saw them in the thumb earlier in the talk. We see them here as well. So you can have those little accessory ossicles or sesamoid bones in the toes as well as the thumbs. So if we look at this, I put this in here to kind of give you an idea about mortise. When we're looking at the x-ray on the left, if we draw a line down and we come right down the middle of the tibia, look where it lands in reference to the talus, and that is way off. So that's a huge concern because even if you put that in a cast, all of a sudden that joint is majorly disrupted. That joint is no longer stable. So when it's all said and done, the whole goal of shooting all this hardware in here is to get that mortise, that ankle joint, back to where it belongs. And that's huge because, again, if you don't, now all of a sudden you got an unstable joint and this becomes profoundly arthritic. Now the person has a lifelong difficulty with just simple ambulation. So here's a simple lateral malleolus fracture. However, if we look at the ankle joint, there's no significant mortise disruption, nor do they have pain over the lateral malleolus or the medial malleolus. So this is a very simple injury, pretty easy to take care of. This is not an unstable joint. This is a simple lateral malleolus fracture. However, look at this one. If we look at this person and we see there's substantial widening of the joint, and again, if we draw that line down the middle of the tibia and look where it bifurcates that talus, all of a sudden we got a real problem here. And that deltoid ligament injury is absolutely a surgical problem. So when you start seeing the medial malleolus involved, you better be thinking, hey, we got an unstable joint here. Lateral malleolus by itself usually get by okay as long as it's not too comminuted, but if you got lateral and medial, unstable. If you have a medial, probably unstable. So these are kind of differences in how you're going to take care of these. At the end of the day, if you're not sure, nobody's going to fault you for putting them in a splint or an OCL, a boot. Keep them non-weight bearing, ice elevate, and refer to the appropriate specialty. This is an example of a bimalleolar. Earlier we saw lateral, we saw medial. Now we've got both sides, bimalleolar. So think about if you've got the joint here, this side of the joint is disrupted, this side of the joint is disrupted. How stable is that joint? It's not. It's an unstable injury, so it needs to be fixed. And then occasionally you'll see a word called trimalleolar. Trimalleolar, the only difference is you get the medial side, lateral side, and then you also get a little bit of the posterior tibia. At the end of the day, nobody cares if it's bimalleolar or trimalleolar, both equal operative management. Here's a picture very similar to what we saw a little while ago, where the lateral malleolus was broken. Not too bad, but it's broken. But when you look at the widening of that mortise, that's a big deal. Now, the difference is in this picture, or in this patient, they have significant tenderness, not just laterally, but medially. So with that significant medial tenderness and widening of the joint, this person's going to probably need operative management because, again, they've got an unstable joint. So these are just some of the reasons why you think what we're thinking. But at the end of the day, again, nobody's going to fault you for immobilizing it, ice, elevate, non-weight bear, and appropriate referrals. So I'm going to keep scooting along, so I try to get you guys done earlier, but we'll take a break between this and advanced imaging. But again, try to keep it moving for sake of your time. Looking at skeleton, as far as spine goes, obviously you guys know there's 5 vertebral bodies. We're looking for asymmetry, things called spondylolisthesis, and I'll show you pictures of that. Very common to see these, especially in folks, women over 50, typically present at either L4-5 or L5-S1, where one bone is slipped anteriorly on the other. We look for things called pars interarticularis fractures. This is another case where the oblique views can be helpful, looking for what some of you may be familiar with, the Scotty dog picture, looking to see if the Scotty dog has a broken neck or not. Also, obviously look for compression fractures and or degenerative changes. So this is diagrammed out for your own review. You know, it's pretty basic anatomy. This is a picture of a pars interarticularis fracture. So where we see the black arrows and we see this absence of bone, that is where the pars interarticularis would be connected. The reason that's important is that's what connects, the pars interarticularis is what connects this whole big vertebral body with the posterior arch back here. If those two things are separate, it allows this guy, this L5 body, to start moving anteriorly or moving away. As that happens, the hole where the nerve root comes out gets compressed, and that causes a lot of butt, hip, and leg pain or sciatic symptoms. One of the ways to see that on x-ray, clearly the picture on the left, the lateral view, it's pretty obvious, but they're not always that obvious. So sometimes we'll get what we call the oblique views or Scotty dog views. And if we look at this picture on the right, we see that Scotty dog diagrammed out quite nicely. And we see what we're looking for is the neck of the Scotty dog. Is there, some people will say a broken neck, some people say a collar. Nonetheless, as we look at the Scotty dog here, we don't see bone. So this Scotty dog either has a broken neck or the Scotty dog has a collar. I don't care what you call it, it's disrupted. If we go up and look at the Scotty dog up at L3, we got the ear of the Scotty dog, the nose of the Scotty dog, jaw, front, body or leg, tail or back leg, body, and we come up. The neck of that Scotty dog is intact, so there's no fracture there. There's no fracture here, but there's clearly a fracture of L5. Those will be bilateral. You'll get a left oblique and a right oblique, and generally speaking, pars fractures are going to be bilaterally. Rarely are they unilateral, but occasionally they're bilateral. If you're worried about a pars fracture by itself, CT is a better test. It'll pick it up 99% of the time. MRIs miss these about 20 to 30%. So the question then is, am I more concerned about the disc and the nerve root and the soft tissue? Then the MRI is probably more reasonable. If you want to know, do I or do I not have a fractured pars, a CT scan is a better test. If you're not sure, don't order either of them and let the spine guys figure it out. As I said a moment ago, when that occurs, when that fracture occurs at L5, L4, it doesn't matter, whatever level it occurs, that's now no longer connected. Then we see the slip. And so here's that slip of L5 on S1. Spondylolisthesis are generally graded, grade 1, 2, 3, 4, and 5. Grade 1 implies 0 to 25% slip. Grade 2 is 25 to 50, grade 3, 50 to 75, grade 4, 75 to near 100%, and anything over 100% is grade 5. I will tell you that in my practice, I've seen innumerable grade 1s more than a handful of grade 2s and about 3 grade 3s and no grade 4s and no grade 5s. So most of the time when those occur, they're usually developmental congenital type things. Most degenerative spondies are grade 1s and grade 2s. And so that's a pretty common thing for us to see. And again, rare occasions 3s, and have you ever seen a 4? So this is a normal AP view of the spine. If we're looking at it, it's nice and straight, no scoliotic defect. We can see the sacroiliac joints. We can see the ball and socket of the hips. So there's a lot of things there that we can look at. We see the lower ribs coming into play, the 12th rib. When you count these down, you got the rib at 12 and then L1, 2, 3, 4, and 5. Watch the numbering. Sometimes a person will have a transitional vertebrae and might have a 6th vertebra, which is really kind of what we call transitional vertebra. So sometimes that's there. That's only about 10% of the time. It's really only an issue if you're worried about operating or doing a procedure. It's not a pathologic thing. It's just an anatomic thing. When we look at this lateral view, this is a good view looking at it from the side. We see the belly here, back here. Bigger guy is the bone. Space in between is the disc space. We don't see disc, we just see the space. And if we look at it, we see good space, not so good space. That L5S1 discogenic space should be the same as the levels above. So when we see that, that's that classic degenerative disc disease that everybody worries about. And I tell a patient when they have it, don't get too close to me, like COVID. I don't want to catch it. I don't want degenerative disc disease. It's a process of aging. We all got it. Welcome to the 30 and over club. Now the question then becomes, is that really what's causing that person's problem? And in some cases it is, in other cases it's not. But I wanted you to see a good example of just typical degenerative changes in the lumbar spine. Occasionally you get an x-ray and you find stuff that you didn't want to find. Here's a good example. This is a patient I saw who was examined complaining of some back pain, and I got the x-ray and I thought, oh shit, I didn't expect this. And this guy has a huge AAA. It fortunately was not leaking, but he absolutely had a AAA. Just a quick side story about this guy for you guys, especially people that are practicing every day. The textbooks say when you find a AAA, you're supposed to get an ultrasound to measure it, assuming it's a stable AAA, of course, not a leaking, but a stable AAA. And this guy was a stable AAA. Vitals were good. His back pain hadn't changed in months. It's, you know, it's clearly not an acute leak. So I sent him for the ultrasound. Ultrasound gets read as no AAA identified. Now, keep in mind, this is 24 hours after this x-ray. And I'm looking at the x-ray and I'm like, this guy's got a AAA. So I sent him back to the imaging center and I got a CAT scan the next day. So now 2 days later, CAT scan's read as AAA infrarenal 5.5 centimeters. Now, why am I telling you all that? Because the guy was a little portly, as you would be surprised here in Missouri. He was a little portly. And so people that are heavier, ultrasound definition goes down. So if you got a patient that's really got a lot of adiposity, you may want to consider getting a CT if you're really concerned about that over it. Now, I'll be the first to admit, ultrasound is the gold standard. That's what you're supposed to do. But I've had a couple examples, and that's one of them where the ultrasound didn't penetrate well enough to see it because of the adiposity. And it's not the tech's fault, it's not the doc's fault. You just couldn't see it very well. It's one of the limitations of ultrasound. So, but nonetheless, this guy actually absolutely had a AAA and he did fine. But, you know, it's one of those things where you're getting an x-ray not expecting to find that. Here's another one, patient presented with back pain. He had thoracolumbar pain. He's about 35, great shape, x-rays, back looks great. And what do we find here? Well, he doesn't have a spine problem. He needs his gallbladder yanked. So he got his gallbladder yanked, his back pain went away. So sometimes you find things that aren't relevant to what you were looking for, but nonetheless, he did well. And then, of course, I think everybody knows this, scoliosis. Scoli is Greek for worm-like. That's where they get the word from. In St. Louis, there's 2 great pediatric centers, whether you go to Glennon or Children's, both are top-notch pediatric centers that are able to take care of skeletally immature folks with this problem. Most of the time, it's more common in girls, and especially if you catch it pre-pubescent or pre-skeletal maturity, there's better outcomes. So the sooner it's diagnosed, the better. If you have a hint of it on clinical exam, get the x-ray, ask for a scoliosis series, and that's all you have to write. Hey, I need a 36-inch view or a scoliosis series, and they'll do it. And if they got scoliosis and you're unsure, punt them. Let somebody take care of it, knows how to do it, because prevention is huge with those kids. Thoracic spine, probably compression fracture is the most common thing that we think about. Yes, we see kyphosis and dowager humps and things like that. And we'll talk a little bit more about using advanced imaging later this afternoon. Again, looking at these, the compression fracture is the easiest thing to really look for using the plane radiographs. We look at that, we see a lot of vascularity, atherosclerotic changes in the great vessels. We see the vertebral bodies, and here you see this nice big square vertebral body, same thing below at L1 and L2. But when we look at 12, it looks like somebody stepped on it. And I always tell people it's kind of like stepping on a Coke can. It kind of compresses it down. That's called a compression fracture. It's not broken like a twig breaks. The difference is when you find these things, historically, compression fractures will always look like this. Even if it's a year old, 10 years old, 20 years old, once it's broken, it never grows back. So looking at the x-ray by itself doesn't tell you whether it's old or new, it just tells you it's there. And unless the patient can tell you, oh yeah, I did that 10 years ago, you don't know. If they have back pain, then you have to image them, use advanced imaging, whether it be MR or bone scan to kind of discern whether there's acuity or not. So again, we'll talk about that a little bit more this afternoon. Cervical spine, looking at soft tissue, looking for soft tissue swelling, look in the anterior vertebral body, posterior vertebral bodies, look at the spinous processes. If you're unsure, sometimes flexion extension views can be helpful, especially in the presence of trauma. Usually this is going to be more of an ER thing than an office type thing. When you're looking at C1 and C2, you have to get an odontoid view or an open mouth view. That's the only way you're going to see the odontoid and the lateral masses of C1. I will tell you guys a couple of pearls. If you got a patient, especially an older patient that's had a fall, kind of a whiplash type injury where they fell and hit their head, get that odontoid view, because I have had more than a handful of patients that have broken their neck and walked around for days with a C2 fracture before going to the hospital and getting checked. I have had 2 or 3 patients walk into my office after 2 weeks saying, you know, Chris, I fell 2 weeks ago and I thought I just bruised it. I thought I just sprained it. And I get an x-ray and sure as shit, they got an acute C2 fracture. But it's a stable fracture, so that's great, but it's a fracture. So they do happen. It's not this nonsense of you have to be in this rollover extricated MVA in order to break your neck is nonsense. I've had several walk into my office, and I've taken care of several that have walked into the ER after 2 or 3 days or a week and they're not getting better. So another place to think about those kind of odontoid views is in rheumatology patients. Folks with RA will get erosive changes of the odontoid, and they can lead to significant instability, degeneratively speaking. So if you got a patient with rheumatoid arthritis, it's behoove you to get the AP lateral and open mouth view to evaluate that odontoid and make sure there's not any significant abnormalities because of the degenerative rheumatological process. These are just pictures kind of showing you those spinal lines, the anterior spinal line, the posterior spinal line, the interspinous line, the spinal laminar line, and the spinous process line. Basically, we're looking for that normal lordotic shape. The problem is as patients get older, they get degenerative, they lose those contours. So I don't put a lot of stock into that. It's more on clinical exam and tenderness, mechanisms, things like that. That's that top view is that open mouth view I was talking about. They take a picture of patients opening their mouth, shooting straight back. We see the arch of C1 here, and on each side are the lateral mass of C1. This whole thing is C2. So the C2 comes down, and you got the peg of the odontoid of C2 that comes up, and then you got the lateral mass again on the opposite side. So all of this is C2, and then you got the ring of C1 up here that comes all the way around. But that's the best way to actually see that odontoid is on that open mouth view with a plain x-ray. And when in doubt, I get a CT. That'll tell you if it's broken or not in a heartbeat. And sometimes it's hard to discern. Again, you know, you get the 75, 80-year-old patient that has a lot of arthritic changes, makes it tough. It's not easy. So you have to look at their history and put the puzzle together and then figure out what's the right test. This is a normal AP view of cervical spine, nice and straight. But if we look at it here, we see a couple of things. Number one, significant osteoarthritis of the disc space. So we got nice disc space at 2-3, nice disc space at 3-4, horrible 4-5, horrible 5-6. And you say, wait a minute, Henry, you miscounted. C1 is here. C2 is always this big guy. So when you're looking at cervical x-rays, C2 is this big guy. It's always bigger. And then again, we got the disc space, not the disc, but the disc space. And then you got the spinous processes on the posterior aspect. So you can look at these and see, hey, there's classic degenerative changes, disc space loss, consistent with degenerative disc disease in the cervical spine, in this case, C4-5, C5-6. This patient is also very edentulous, meaning they have no teeth, which usually is indicative of really poor bone quality. So there's a red flag to say, hey, maybe they need a little osteoporosis workup. And certainly if there's any operative management planned, it would be behoove of that person to check their bone quality, vitamin D workup, et cetera, before pursuing anything operative. This is a trauma pick. I just threw it in there because everybody always wants to ask about it. When we look at those, we see the vertebral bodies. The vertebral bodies look good till we get down to this guy around C7. When we look at the anterior soft tissue line, it really looks good here. And then all of a sudden, it's significantly swollen down here because when bones break, they bleed. Dry as a bone is a BS mnemonic or BS use of the term because bones bleed. When bones break, they bleed. And when they bleed, they cause soft tissue swelling. Secondly, there's a big avulsion injury. So somewhere back here, probably off of C7, there's a spinous process that's avulsed away. So we know there's ligamentous disruption in the posterior aspect. This is a big problem because when you got one side, posterior side is broken, anterior side is broken, and the cord goes right through the middle, odds are it's unstable. So it's a little beyond the scope of the talk, but I wanted to show you that. That learning radiology I put down there at the bottom, and I think that's at the end of the talk as well, is a really good site to look at lots of different types of x-rays, and it's free. So it's kind of a nice one if you say, man, I'm really good with chest, but I don't know anything about abdomen. Well, they have lots of those on there. So it's a good site to go to. And as far as trying to learn some things or brush up on certain pathology that you may not be comfortable with. Skeletal, general, and I'm almost done with this. Most people agree skull x-rays are a waste. If you have facial bone injuries, get a CT scan, non-contrasted CT. That does not count for nasal bone. If you got just a nasal, somebody got punched in the schnoz, get an x-ray of the nose, nasal bone x-ray, it's easy to find. If, however, you got somebody that got punched in the orbit and there's potential for orbital 4 fractures, zygomatic arch fracture, things like that, CT is way faster and way more definitive than facial bones. In the old days, when all we had was CT and you had to call in a tech, it was a pain in the butt. Nowadays, everybody's got a CT and it takes 5 minutes and it's a non-contrasted study. Avoid doing body grams, meaning that when the patient comes in and they had a fender bender at Walmart and the whole reason they're there is because their attorney told them to come in and that was a week ago, and they tell you, oh, it hurts everywhere. You're not going to x-ray everywhere. X-ray where you're concerned about. Be a good steward of that technology. It's a mandible fracture. Typically, like I talked about ring fractures, when mandibles fracture, they tend to fracture down by the mentum, and then they usually will break up high. You don't really care because at the end of the day, if it's broken, it's broken, and usually maxillofacial will take care of that. Sometimes plastics is the other group that will usually take care of that, depending on your facilities and how rural or urban you are. Nasal bone fracture, pretty easy to see. You don't need anything fancy. They got a broken schnoz. Couple unusual pictures, not mine. Nail in the head, cell phone in places where they don't belong. I think this was a prison x-ray, actually. Psych x-ray, patient swallowing nuts and bolts. And here's a good example of things that probably need to go get fished out, because that's not a good answer for your colon. Foreign body in the urethra. Yes, urethra, that I don't get that, but okay. And then here's those references I'd mentioned. Learning Radiology is a really good one. MedEd Virginia is a good one. Radiology Masters is actually pretty good as well. Some of them they charge after you do part of it, then they want to charge you to continue, but you can actually get a couple of good things out of it before you have to pay for it. There's also a textbook by Dr. Campo, C-A-M-P-O, who's an NP, and it's only about 200-300 pages, and it's got a good introduction to a lot of the radiology as well. I've looked over her book, and it's got some good info. So a couple of those things just to kick around. Okay, I've been talking, I'm damn near hoarse. That you guys have got to have some questions or you're asleep. If there's something you want to ask me about, you're like, oh, I'm too embarrassed, I don't want to do that, I put my email up there. That's my straightaway email. I'll be happy to answer any questions. My understanding is you guys will have access to this talk for quite some time. So I tried to point out the abnormalities and put the arrows, because it's hard when you're sitting here for hours on end listening, and I don't want you getting carpal tunnel. So my suggestion is we take about a 10-15 minute break, let everybody stretch. And then when we get back together, we'll go over advanced radiology, which is way shorter. I promise, only like 30 slides, not 200 slides. And we'll get you guys wrapped up a lot earlier than anticipated because of cutting some of the breaks short. So if you don't have, oh, somebody did ask me a question. Hold on. Rebecca wants to know, what is the best way to physically examine for scaphoid fracture? So a couple things. Number one, most scaphoid fractures, patients don't come screaming and hollering in the ER. They feel like they got a wrist sprain, except the sprain doesn't get better. Number two is they have point tenderness over the anatomic snuff box, and that's that area I was showing you guys on the x-ray. If you look at your thumb at the CMC joint, it's proximal to the CMC joint, but not quite to the distal radius. And so if they got point tenderness there and they had a recent fall, I would absolutely get an x-ray of the wrist, and I would even probably get scaphoid views, which again only take about 2 minutes because it's only 2 extra views. And if I'm really suspicious about it, put them in a thumb spica splint. It has to be a thumb spica splint, not just a distal radius splint. Ice elevate thumb spica splint, and within a few days get them seen by a specialist. If there's still ambiguity and they're still not sure, but they act like a scaphoid fracture, but the x-rays are negative, a lot of times they'll put them in a cast, re-x-ray it in a week to 10 days. If they're still sensitive and they're still not sure, get an MRI. MRI will show bone marrow edema, especially if it's a non-displaced fracture. You can see bone marrow edema on MRI quite nicely, whereas CT would not show that. If there's displacement, CT will pick it up in a heartbeat. So a couple of thoughts there. But I will suggest that we go ahead and break.